الله الرحمن الرحيم. بسم الله الرحمن الرحيم. الصلاة والسلام على أشرف المرسلين. نبدأ بفضل الله وحمده فعاليات المؤتمر 59 للجمعية المصرية لجراح المسالك البولية. نرحب بالسادة الضيوف الكرام من جامعات مصر ومستشفيات جمهورية مصر العربية بجميع قطاعات وزارة الصحة والسكان والتأمين الصحي والمستشفيات التعليمية ومستشفيات المؤسسة العسكرية والشرطة، وضيوفنا الكرام من جميع دول العالم من أبناء مصر المهاجرين. ونبدأ أول جلساتنا الخاصة بشباب الأطباء، وللأسف لسه بيفطروا في الغالب، فنرحب باللغة الإنجليزية. Welcome for all of our guests in the 59th Annual Congress of Egyptian Urological Association. We will start the first session of young urologists. ويتفضل الدكتور حافظ مناع بتقديم الجلسة.
السلام عليكم، كل سنة وحضراتكم طيبين. احنا دلوقتي الدكتور شادي يسا هيتفضل.
صباح الخير. أنا الدكتور شادي هاني، نائب مسالك مستشفى الجو التخصصي. وأول حاجة بحب أشكر جمعية دكتور حسن دكتور شريف وباقي أساتذتي على الفرصة إن أنا أتكلم على التوبيك النهاردة. هو كلينيكال أوديتنج. هو توبيك يعني جديد شوية، إحنا مش متعودين إن إحنا نتكلم عنه في مصر، بس فرصة حلوة إن إحنا نتكلم عنه ونتعلم، وكمان نشير الإكسبيرينس بتاعتنا في الجو التخصصي على الأوديت عملناه في المستشفى. اوكي، في الاول دي الاكنولجمنتس، بعد كده دي الاجنده اللي احنا هنفولو ثرو في الثلث ساعه الجايه. اول حاجه ايه هو الاوديت ده اصلا، و internationally الناس شايفه الاوديت عامل ازاي، اوكي، وقد ايه مدينه اهميه، وده اللي احنا هنتكلم فيه اكتر. ازاي اعمل كلينيكال اوديت، هو ليه مهم، وايه التشالنجز اللي احنا واجهناها او اي حد ممكن يواجهها لو عمل اوديت في مصر، اوكي، والاكسبيرينس بتاعتنا اللي هو الاوديت نفسه. اوكي، لو خدنا بالنا كل البلاد اللي ظاهره قصادنا دي هي بلاد بالنسبه لهم الاوديت مهم جدا في البروجرام بتاعهم وفي طريقتهم ان هم بيرقوا فيها الدكاتره الصغيرين من بوزيشن لبوزيشن اعلى، انه لازم علشان تترقى وتجو ثرو الباث واي بتاعك لازم جزء اساسي منه انك انت تعمل كلينيكال اوديت. حتى لو خدنا بالنا كل الكبار في الطب، انجلترا، كندا، امريكا والاتحاد الاوروبي. كمان انا لسه حاطط السلايد دي امبارح، انا كنت بقرا امبارح انه كمان دول الخليج بقت بتهتم جدا بالاوديتنج، ان هم علشان يحطوا حد في منصب عليا بيبصوا كمان هو عامل اوديتس ولا لا. اوكي، فعلى سبيل المثال مثلا انجلترا طبعا اكتر بلد مشهوره ان هي تعمل اوديتنج، ولازم تعمل فيها اوديتنج عشان تبروسيد، يعني حتى عشان تكمبيت على تريننج جوبز اللي هي كل الناس بتحاول ان هي تسعى لها علشان تتمرن في مستشفيات انجليزيه في بروجرام محترم اخره تقدر تبقى كونسلتنت. من ضمن الحاجات المطلوبه بيطلب منك تشيك ليست. التشيك ليست دي حاجات انت لازم انت تعملها بنفسك علشان تحط نفسك في بوزيشن كومبيتيشن انك انت تقدر تاخد الوظيفه التدريبيه دي. فمن ضمن الحاجات زي ما احنا شايفين هاير كواليفيكيشن بتاعك ماجستير او دكتوراه، لو معاك ريسيرش اوديت ده اللي احنا بنتكلم عنه، برزنتيشنز، تيتشنج، خدت جوائز، اللوج بوك بتاعك والليدرشيب وهكذا. بس اون سايد نوت كده، لو خدنا بالنا انه البوينتس هو كلهم على بعضهم الماكسيمم بوينتس تقدر تجيبها، مثلا دي التشيك ليست بتاعت السنه دي 78 نقطه، من ضمنهم الاوديتس الماكسيمم بوينتس تقدر تاخدها فيها 10 نقط، اما الريسيرش مثلا 9 نقط. فلو خدنا بالنا الهيد تو هيد هم حاطين اهميه الاوديت تقريبا زيها زي الريسيرش، يعني الريسيرش ممكن يقعد سنين ولازم فيه مجهود كبير جدا، فحاطينه equally important الاوديت. فايه اللي يخليه مهم قوي كده، ان هم دول جامده زي انجلترا وزي امريكا بيحطوه في الحته المهمه دي. تعالوا نعرف الاول يعني ايه اوديت اصلا. في الاول الاوديت ده is the quality improvement process، انك انت الاوديت ده عن طريقه انت بتقيم الشغل اللي بيحصل في الوحده عندك في المستشفى، وتحاول انك انت تحسنه بحيث ان هو يبقى قريب للستاندرد بتاع الجايد لاينز بتاع الاسوشيشنز اللي بتحكم المهنه، زي الايجيبشن يورولوجيكال اسوشيشن، اليوروبيان رويال كولج، وهكذا. ف والموضوع ده علشان يتعمل لازم يتعمل بطريقه سيستماتيك. يعني مثلا انا عندنا مشكله، مثلا الاوديت ده ممكن يتعمل على اي حاجه. يعني مثلا احنا عندنا مثلا مشكله في الوحده ان احنا مثلا ما بنكتبش الشيت العيان كويس مثلا. فاحنا ما ينفعش ان احنا نصحى مثلا الصبح النواب والاخصائيين يقول لك تعالوا يا جماعه احنا حاسين ان في مشكله، تعالوا نشوف هنصلح المشكله دي ازاي، هنكتب مثلا جوجل الشيت بيتكتب ازاي وهكذا. لا، الموضوع ما يمشيش كده، لازم يبقى موضوع سيستماتيك بطريقه معينه، وهنتعلم مع بعض ازاي نعملها بحيث انك انت تعرف المشكله فين بالظبط وازاي تحل المشكله دي، وتحط الافورت بتاعك فين بالظبط عشان تلاقي الاوتكم اللي انت عايز تشوفه. اوكي؟ بس فازاي نعمل كلينيكال اوديت؟ انا حاولت ان انا احطها بطريقه منظمه، فهنعمل الموضوع ده في 10 ستيبس. اوكي؟ وانا حسيت ان هو لو احنا قلنا كلام كده ستيب ورا الثانيه ورا الثالثه محدش هيفهم حاجه ومحدش يتعلم حاجه. فقلت مثلا ان احنا نخلي مثلا اكزامبل بسيط على فكره اوديت ونمشي بيها بالستبس واحده واحده علشان نعرف ازاي نعمله. اول حاجه انك انت تختار توبيك، وانه التوبيك ده لازم يبقى ريليفنت ولازم يبقى برايورتي للوحده بتاعتك. بمعنى يعني مثلا احنا شايفين مثلا ان في مشكله كبيره قوي في الوحده عندنا، فما ينفعش ان انا اسيب المشكله دي ولا انا هعمل توبيك على اوديت او احاول احل مشكله فرعيه. لا، لازم ان انت تلاقي توبيك يكون ريليفنت للوحده. في سبيل المثال مثلا انه المشكله مثلا او التوبيك اللي انا هاخده ان مثلا البوست اوبراتيف نوتس بتاعت العيانين في المستشفى او في القسم بتاعي مش بتتكتب صح. فمثلا دي المشكله اللي انا هشتغل عليها، فده التوبيك بتاعي. اختار التيم بتاعي. التيم بتاعي مش لازم يكون دكاتره، ممكن دكاتره، ممرضين، عمال، سكرتاريه، مش لازم يكون دكاتره. اوكي؟ فانا اخترت التوبيك. تاني حاجه define explicit evidence based standards اللي على اساسها اقيس. فلازم اختار المسطره اللي انا على اساسها هقيس انا فين. بمعنى انه في المثل اللي احنا كنا بنقوله الرويال كولج مثلا كانت نشره ستاندردز معينه على اساسها بكتب البوست اوبراتيف نوتس. ده المثل اللي احنا ماشيين بيه. فهم حاطين مثلا كانوا حاطين 19 بوينت لازم يبقوا موجودين في البوست اوبراتيف نوتس علشان تقول ان البوست اوبراتيف نوتس دي بيرفكت. فانا هحط المسطره بتاعتي اللي هقيس عليها الاوديت بتاعي اللي هو المثل اللي احنا بنقوله هو البوست اوبراتيف ستاندردز بتاعت الرويال كولج. اوكي؟ فانا اخترت التوبيك، حطيت الستاندرد اللي انا على اساسه هشتغل الاوديت ده. نمبر 3 ستيب نمبر 3 جت ذا نيدد هوسبيتال بورد ابروفل. انت لازم تلاقي فيه موافقه المستشفى، وده هنتكلم فيه بعد كده ان ده كان تشالنج شويه لان الناس مش عارفه قوي ايه هو الاوديت. بعد كده تكولكت الداتا، هتجمع الداتا اللي على اساسها هتعرف تكوانتيفاي المشكله، تعرف المشكله فين. فايه المهم قوي انك تسال نفسك السؤال: ايه الداتا اللي انا هجمعها؟ هجيبها منين؟ ومين اللي هيكولكت؟ مثلا في المثل اللي احنا كنا بنقوله ايه هي الداتا؟ ان انت هتجيب البوست اوبراتيف نوتس نفسها، الورق نفسه اللي انت بتكتب فيه البوست اوبراتيف نوتس. وير تو فايند ات؟ هتلاقيها فين؟ هتلاقيها في فايل العيانين سواء في الارشيف او في عيانين في القسم نفسهم. ومين اللي هيكولكتد؟ اي حد في التيم، ممكن دكاتره او كده، بس يستحسن يبقى دكاتره طبعا. بعد كده سيلكت ذا ابروبريت سامبل سايز. هتحط كام واحد في الاوديت ده؟ عاده بيبقوا من 20 ل 50 كيسز لو انت عايز تبدا لسه في الاول، بس طبعا ممكن في اوقات يبقى اكتر كتير كمان عن كده. بعد كده جبت الداتا بتاعتك، هتبدا تانلايز الداتا دي. في المثل اللي احنا بنقوله انه مثلا جبت ال 50 عيان مثلا البوست اوبراتيف نوتس بتاعتهم، همسك اوبراتيف نوت اوبراتيف نوت. طيب انا دلوقتي والرويال كولج بتقول لازم في 19 كرايتيريا لازم يبقوا موجودين. اوكي؟ طيب انا اول عيان جاب كام 19 كرايتيريا؟ 8. اللي بعده 10، اللي بعده 12، وهكذا. في عيان مثلا تلاقيه مكتوب 19 كلهم، وهكذا. وتبدا تحلل المشكله فين وازاي تعرف فين الجاب. وهي دي مهمه جدا انك انت تايدنتيفاي الجاب، انا فين بالنسبه للستاندرد، وتحاول انك انت تبريدج الجاب دي انك انت عن طريق الداتا اللي انت جمعتها في الاسم عندك في المشكله دي. وبعد كده بناء على ده تبدا تحاول انك تimplement changes، انك انت تبدا تحط حاجه مختلفه في الاسم عندك عشان تصلح المشكله دي. بمعنى مثلا في مثل بوست اوبراتيف نوتس انا دلوقتي عندي مشكله مثلا ان النواب مش فاكرين ال 19 نوت كلهم، فانا ممكن مثلا اعمل مثلا PDF وابعته على جروب الاخصائيين بحيث ان هم يفتكروها. ممكن مثلا في اوضه المسالك او في اوضه القسم مثلا اعمل بانر واحط عليه ال 19 بند دول عشان الناس كلها تفتكر. ممكن مثلا اتفق مع رئيس القسم ان احنا مثلا نعمل سيشن مثلا كل شهرين او كل شهر وات بحيث ان احنا نتعلم ازاي نكتب الحاجه دي سوا. اوكي. وبعد كده بعد ما خلصنا الستيب نمبر 8 الباقي سهل. هتعيد بعد ما انت خلاص حطيت التشينج when you implemented the change المفروض انك تتوقع ان الدنيا تتحسن وانك تبدا كل البوست اوبراتيف نوتس تبقى موحده وكل الناس تمشي عليها زي المسطره اللي احنا قسنا عليها. فساعتها هتعيد السايكل تاني، هتعيد الاوديت تاني، بس هتستخدم نفس الميثودولوجي وتشوف هل الدنيا اتحسنت ولا ما اتحسنتش. لو اتحسنت حلو، بس اهم حاجه انك تخلي الموضوع سستينبل، بمعنى انك انت تحافظ على ده. مش معنى ان احنا خلاص عملنا اوديت والدنيا اتحسنت فخلاص بقى بعد ما المولد انفض يعني بالبلد زي ما بنقول خلاص كله يرجع زي ما كان، لا. ولو الدنيا ما اتحسنتش ساعتها تري اساس تاني وتشوف المشكله كانت فين. وده دايجرام بيلخص الموضوع بيمشي ازاي بالظبط. في الاول بتختار التوبيك، وبعد كده بتسيت الستاندرد، بعد كده بتكولكت الداتا، بعد كده بتانلايز الداتا، وبناء على الاناليسيس ده بتمبلمنت التشينج، وبعد كده تستنى شويه، وبعد كده علشان عقبال ما التشينج ده يبقى استابلشد في الوحده بتاعتك، وبعد كده تعمل ري اسسمنت وتشوف الدنيا مشيت وراحت فين. ايه هي اهميه الاوديت؟ يعني بالمنطق اهم حاجه ان العيان اول واحد هو اللي بيستفيد، دي اهم حاجه. تاني حاجه ان الكواليتي بتاعت السيرفيس اللي بتقدمها في المستشفى بتفضل ثابته ما كانش بتتحسن. وهو ده وهو ده الفكره، هم ليه بره بيهتموا قوي بحته الاوديت دي؟ علشان مش عايزين الاوديت او مش عايزين الكواليتي في المستشفيات بتاعتهم تبقى ديبندنت على اشخاص. الاشخاص دول راحوا الكواليتي قلت، الاشخاص دول سبتوا الكواليتي موجوده. هم عايزين تبقى الكواليتي انستتيوشنال، نابعه من الانستتيوشن نفسها، بحيث انه اي حد نايب اخصائي، لان الدكاتره بره بيروحوا ويجوا كتير، بيلفوا من المستشفى دي، فمش عايزين الكواليتي بتاعت السيرفيس تتاثر بالناس بتمشي او بتروح، فده مهم قوي. رابع حاجه promoting professional development، انه انت اتعلمت وعلمت الناس مثلا على الناس اللي احنا كنا بنقوله ازاي نكتب بوست اوبراتيف نوت صح، فده معناه انك انت بتتعلم وبتعلم غير نفسك، بتعلم غيرك ازاي تتحسن وتعمل حاجات زي الجايد لاينز. وانهانسنج ريسورس يوتيلايزيشن، انك انت بتتعلم ازاي تستخدم الريسورسز اللي عندك حتى لو كانت حاجات بسيطه، انك انت تعمل فرق. ايه هي التشالنجز اللي ممكن تواجه اي حد بيعمل اوديت او بيحاول يعمل اوديت في النظام الصحي المصري لغايه دلوقتي؟ انه للاسف يعني في limited resources relatively compared بالناس بره. كمان انه مفيش فريم ورك اداري تقدر تحته تعمل اوديت، يعني دي برضو مشكله واجهناها، ان احنا لما بنلاقي الموافقات من المستشفى هو مش فاهم، هو بيبقوا عايزين يساعدوك في كل حاجه بس مش بيبقوا عارفين انت عايز تعمل ايه. بيقول لك هو ده ريسيرش، طب هتعمل ايه، طب هتوزع حاجات على العيانين، هتعمل ايه بالظبط، هم مش فاهمين قوي، فده بيحتاج شويه مجهود، والناس لازم يكونوا عايزين يساعدوك علشان تقدر انك انت تعمل حاجه زي كده، especially انت بتبدا من تحت خالص. ودي حاجه كنت هقولها في الاخر، ان احنا مفيش previous experience تبني عليها، فاحنا لسه بنبني حاجه جديده بس. وكمان ان احنا من ضمن برضو المشاكل ان احنا نفسنا بنريزيست التشينج، احنا نفسنا بنقاوم ان احنا نغير حاجه. ممكن حد يقول لك يا عم اوديت ايه ومش اوديت بتاع، خلينا الشغل ماشي كده والدنيا ماشيه كده فخلاص هنفضل ماشيين كده. ففكره انه مفيش ويل قوي ان احنا نغير ونحسن، دي برضو تشالنج في حد ذاته هنا انك انت تابلاي اوديت هنا. كده احنا الاجنده اللي احنا ماشيين عليها خلصنا كل الحاجات دي، فاضل ان احنا نشرح الاوديت نفسه اللي احنا عملناه. الاوديت هو ده التوبيك بتاعه، هو يبان يعني طويل شويه بس هنشرحه واحده واحده. انه احنا الاوديت عملناه في مستشفى الجوي التخصصي. الفكره بتاعته بدات ازاي؟ انه خدنا بالنا انه المفروض المستشفى الجوي التخصصي في التجمع، فتعتبر منطقه التجمع منطقه تعتبر نسبيا راقيه سوشيو ايكونوميكلي، انه الناس البيشنتس اللي المستشفى بتخدمهم بيعتبر مستواهم المادي والاجتماعي عالي. بس اللي احنا خدنا بالنا منه انه مع ده المستوى الثقافة والوعي الصحي للمرضى very poor، بحيث ان هو عيان مثلا يجي لك لابس شيك وكل حاجة وراجل انتلكتشولي محترم وكل حاجة، بس تلاقيه في الثقافة الطبية والوعي الطبي عنده في مشكلة. فده هنا من هنا جت الفكرة، ده الجاب اللي احنا اشتغلنا عليه، ان احنا نحاول ان احنا نحسن الانفورميشن بتاع العيانين عن طريق ان احنا نديلهم انفورميشن ليفلتس زي اللي بنشوفها بره في اي حته. اوكي. وبعد كده نقيس قبل هنوزع وهنقيس هم استفادوا منها ولا لا وعرفوا عن الكونديشن بتاعتهم ولا لا. بعدين ازاي ان احنا قبل ما نديلهم الانفورميشن ليفلت بنديلهم كويشنير في 5 اسئله بس بيريت قد ايه هو استفاد او قد ايه هو فاهم الكونديشن بتاعته من 1 ل 10. وبعد كده نديله الانفورميشن ليفلت وبعد كده بنديله الكويشنير برضه تاني ونأسس الدنيا اتحسنت ولا لا، السكورز بتاعته اتحسنت في الكويشنير ولا لا. اوكي. عملنا الموضوع ده على 5 كونديشنز بس، والكونديشنز دي هم اكتر حاجات بنشوفها في العياده، هو البي بي اتش، الستونز، اليو تي اي، اوفر اكتيف بلادر، وحبينا نحط حاجه للاطفال اللي هي نوكتورال انيوريسيس. انا يعني بشرح كده في عجاله علشان لو الوقت، فده باختصار التوبيك بتاعنا. اوكي. بسرعه كده اوتلوك على المستشفى عندنا. مستشفى جو تخصصي، يعني احنا 400 سرير، 8 رعايات فيها اكتر من 41 اي سي يو بيد. الامرجنسي ديبارتمنت عندنا فيري بيزي 24 ساعه، عندنا 11 اوضه عمليات، عندنا 100 عياده خارجيه، بنعالج مش بس عسكريين كمان مدنيين او الاغلبيه مدنيين اكشلي، وعندنا ليفر وكدني وبون مارو ترانسبلانتيشن، وبلس انه في دلوقتي مبنى جديد بيتبني 6 ادوار علشان يكسباند الكاباسيتي بتاعت المستشفى. احنا في اسم المسالك 31 كونسلتنت بنعمل كل تايبس اوف سيرجري، راديكال سيستكتوميز، كدني ترانسبلانتس، اندويرولوجي، بيدياتريكس، لاباروسكوبي، اوبن سيرجريز، كل حاجه بنعملها باستثناء الروبوت يعني، بس برضه في كلام انه الروبوت هيجي يعني، بس لسه الموضوع ده مش اكيد. بنعمل اون افريج 70 عمليه في الشهر، وبنشوف 400 عيان في الاوت بيشنت كلينيك كل شهر. اوكي. ده اللي احنا كنا بنتكلم فيه، انه بالرغم من المستوى العالي بتاع العيانين بالمستوى السوشيو ايكونوميك، بس برضه الهيلث اديوكيشن مش احسن حاجه. فده الجاب اللي احنا اشتغلنا عليه، والكونسلتنتس بيحاولوا ان هم يكمبنسيت ده، ان هم يشرحوا للعيانين اكتر ويحاولوا ان هم يفهموهم اكتر، بس ده بيجي على حساب الكونسلتيشن تايم، الكونسلتيشن تايم بيبقى زياده قوي. فده اول حاجه اللي احنا عملناه، ده اللي احنا كنا بنقوله، ان احنا اخترنا التوبيك ان احنا نوزع عليهم انفورميشن ليفلتس، وبعد كده نشوف هل هم استفادوا ولا لا، هل هم اتعلموا اكتر ولا لا، عن طريق الكويشنير. في 5 اسئله بس بنسالهم له قبل ما ياخد الانفورميشن ليفلت وبعد ما ياخدها، ونشوف هل هو اتعلم فعلا ولا لا. تاني ايمز برضه في سكندري ايمز كنا بنشوفهم، هل الموضوع ده هيخلي الكونسلتيشن تايم اقل، وقت الكشف هيبقى اقل ولا لا. واخر حاجه از ات فاينانشلي فيزبل ولا لا، هل احنا هنعرف نفاينانس ده ولا لا، يعني دراسه جدوى يعني من الاخر. اوكي. بعد كده زي ما قلنا حطينا الستاندرد على اساسها طبعا كل الجايد لاينز، واحنا هنا بنحب ان احنا قوي، دي حاجه نسيت اقولها، في اي اوديت في العموم بنحب ان احنا نحط اللوكال جايد لاينز. فهنا اهمهم هو الايجيبشن يورولوجيكال جايد لاينز، طبعا دكتور شريف موجود معانا، فدي اهم حاجه، انك انت الايجيبشن يورولوجيكال جايد لاينز هي اللي هي اللي بترفلكت اللوكال براكتس هنا. فاحنا طبعا كلهم بيقولوا اهميه البيشنت اديوكيشن، طبعا يعني مش هنخش كتير في القصه دي. خدنا الابروفلز المستشفى، وبعد كده بنكولكت الداتا. دول ال5 اسئله اللي احنا قلناهم للعيانين. هل انت شايف انك انت فاهم الكونديشن بتاعتك ان ديتيل؟ حط تحت ان ديتيل دي 100 خط، انت فاهم فعلا الكونديشن اللي عندك؟ وعشان تقيس شخص فعلا فهم اللي عنده، اساله هل انت تقدر تشرح لحد تاني اللي عندك فعلا ولا لا. يعني لو انت اتسالت انت تقدر تشرح حاجه للشخص الاخر، هل انت هتعرف تشرحها ولا لا؟ ده السؤال التاني. هل انت شايف انك انت سالت كل الاسئله اللي انت المفروض تسالها ولا لا؟ هل انت شايف، السؤال الرابع، هل انت شايف انك انت كان في ممكن اي حاجه نقدر نعملها علشان كشف العياده بتاعك يبقى احسن؟ واخر حاجه الاوفرول ساتسفاكشن بتاع العيان. ودي السكورز بتاعتهم. احنا جمعنا، احنا مبدئيا خدنا 50 عيان، ودي السكورز بتاعتهم. اول سؤال الاوفرول 7.2 من 10. السؤال الثاني انك انت تشرح لحد، هل انت تقدر تشرح حد تاني؟ 4 من 10، وده سكور واطي شويه. وبعد كده 7.9 6.2 6.9. فدي كانت الاوفرول سكورز في اول سايكل في الاوديت. اوكي. بعد كده برضو شفنا الكونسلتيشن تايم، قبلها كان 13 دقيقة، 13 دقيقة ونص، ده السيستم هو اللي جابه، والكوست ما دفعناش حاجة لسه، فاحنا لسه هنشوف بعدها هنعمل ايه. بعد كده زي ما قلنا خدنا 50 بيشنت، وقسمنا 10 بيشنت لكل كونديشن، اللي هو ال5 اللي احنا كنا بنقول عليهم: بي بي اتش، ستونز، يو تي اي، اوفر اكتيف بلادر، نوكتورنال انيوريسيس. واحنا اخترنا ال5 دول بيزد على هوسبيتال ستاتستكس، ان دول احسن او دول اكتر حاجات بتيجي العيادة. انا بعد كده وي انالايزد الداتا كلها. برايم كير ده السيستم في المستشفى اظن عند اغلب المستشفيات، وخدنا الحاجه على اكسل وعملنا الاناليسيز. بعد كده شفنا الجاب. شفنا ان فعلا السكورز دي بتنم من العيانين مش فاهمين قوي فعلا زي ما احنا كنا شايفين. بعد كده بناء على ده عملنا الانفورميشن ليفلتس انه العيانين يقدروا ان هم يقروا الانفورميشن ليفلت دي وبعد كده يستفادوا، بعد كده يتعلموا، بعد كده هنشوف بعد كده الايفكت بتاع الانفورميشن ليفلتس دي في الكويشنير بعد كده. والكويشنيرز الانفورميشن ليفلتس ريفايزد باي اكتر ناس سينيور كونسلتنتس عندنا في المستشفى. بدانا نimplement التشينجز دي ان احنا ندي للعيانين الليفلتس دي. وده مثل للليفلت اللي احنا عملناه. مثلا ده البروستاتا بتاع البي بي اتش، اوكي. ولو خدنا بالنا من ضمن برضو الحاجات اللي احنا حطيناها البوكس الاحمر اللي تحت ده فيه ريد فلاج سيمبتومز، بمعنى ان انا هو عارف ايه هي البروستاتا وازاي بتتضخم ودورها ايه وهكذا وهكذا، بس برضه حطينا في النص ريد فلاج سيمبتومز، يعني انت امتى يا عيان الاعراض بتاعتك تبقى شديده قوي لدرجه ان انت هتيجي الطوارئ. فدي ريد فلاج سيمبتومز، فدي مهمه قوي ان العيان يعرف لا انا كده مش تمام، انا هاجي الطوارئ او اشوف العيان على طول بدل ما يجي على الفاضي على حاجه مش مستاهله. فدي برضو مهمه ان احنا بنوعي الناس ايه امتى يجوا امتى ما يجوش، ايه الطوارئ وايه اللي مش طوارئ. اوكي. وادي الباك بتاع البامفلت هو تراي فولد فبيتني. اوكي. الكلام اللي هو احنا عارفينه وهكذا. وبعد كده بعد ما ادينا لهم قسنا برضو ادينا لهم الكويشنير برضو وشفنا اللي خدتوا بالكم السكورز كلها بتتحسن. هو الكويشن نمبر 4 هو اكشلي بيتحسن لانه السؤال بيقول هل ممكن اي حاجه نقدر نعملها، فده 6.2 يعني في حاجات ممكن نقدر نعملها، بس بعد ما وزعنا الكويشنير السكور قل، فده معناه ان احنا مفيش حاجه نقدر نعملها قوي relatively، فده يعتبر تحسن يعني. الكونسلتيشن تايم بقى بقى 9 دقائق بقى 9 دقائق تقريبا فتحسن. والكوست لو انت هتطبع البتاعه دي بروشور فهتكلفك 20 جنيه، لو هتطبعها A4 بس الوان هتدفع 5 جنيه، ولو ابيض واسود هتبقى 2 جنيه، فطبعا ده كلام فارغ. وحتى لو انت هتعملها بكميه كبيره للمستشفى او كده فالتكلفه هتبقى اقل. بعد كده بنكونفيرم السستينابيلتي وهكذا. بعد كده الاوتكمز والبنفيتس بتاعه الاوديت دي اخر سلايد. better patient care انه العيانين يستفادوا، عرفوا الكونديشن بتاعتهم، better experience و avoiding scam and misinformation. ده كنا بنتكلم في المعلومه دي مع دكتور، كنا بنتكلم في النقطه دي مع دكتور حسن امبارح، انه لما انت تعرف العيان ايه الصح وايه الغلط، هو لو في اي معلومه اتقالت غلط هو مش هيجري وراها. ده اول حاجه. تاني حاجه less load on consultants and staff، انه الكونسلتيشن تايم قل وان هو بقى بيوصل المعلومه بوقت اقل او بمجهود اقل. ثالث حاجه برضو كنت عايز اقولها وهي medical legal problems medical legal benefit، انه لما ودي حاجه انا اتعلمتها من كونسلتنت انجليزي كان بيقول لي واحنا كنا بنكونسنت العيانين في النوتس في الكونسنت فورم بيكتب ان هو قال للعيان واداله الانفورميشن ليفلت، فده بالتالي العيان ده informally consented، ان هو ده اللي احنا كنا بنتكلم فيه في الموافقه المستنيره والقانون الاطباء اللي جاي جديد ده، انه فكره ان احنا لو احنا عملنا انفورميشن ليفلت على كل الكونديشنز في المسالك وعرفنا انكوربوريت ده مع الانفورميشن الكونسنت فورم، ساعتها الدنيا هتبقى احسن ميديكو ليجلي. مينيمال كوست، الكوست قليله، ريبروديوسبل اقدر اعملها في كله. واخر حاجه انه احنا برضو في بلان ان احنا نعمل ويب سايت، الويب سايت ده نحط فيه كل الانفورميشن ليفلتس ونحط فيها كل الانفورميشن ليفلتس على كل الكونديشنز اللي في المسالك، عشان مش بس احنا كمان نستفاد، كمان كل الناس يستفادوا من تجربه القبض بتاعتنا. Thank you.
Thank you, Dr. Shadi. I believe we should move on just to keep the questions at the end. Anyone from the floor has any questions? So our next speaker is Dr. Yasser Nuruddin, is Assistant Professor of Urology. CV جميل ومشرف. Dr. Yasser Nuruddin works as an Assistant Professor of Urology at Northern Ontario School of Medicine in Canada, وكان completed his residency in Banha University، وهو حاليا ليه research interests في الانديورولوجي والشوك ويف lithotripsy والsimulation and surgical education، و has published over 70 articles in peer-reviewed international journals, and he's co-authored 3 book chapters. Dr. Nuruddin also serves as the editorial board member of the World Journal of Urology and as a reviewer of 25 peer-reviewed international journals. It's an honor having Dr. Nuruddin as a speaker in the very first session of the Egyptian Urology Association meeting. تفضل دكتور.
صباح الخير عليكم جميعا. Thank you, Dr. Radi, for this nice introduction. And actually, like I'm very pleased to be here among my professors and colleagues. I'm originally professor of urology at Banham University. That gives me like huge pleasure. I'm currently practicing in Ontario, in Canada, at Northern Ontario School of Medicine. I came all the way down to here actually trying to benefit our young faculty. I'm just gonna, during this presentation, I'm gonna give the information that I would have liked somebody to tell me when I started my career. So it's gonna be some sort of personal experience in addition to some, academic data. So that's the hospital that I work. It's called Sioux Area Hospital. It's actually in a small city called Sault Ste. Marie. That's the nice city of Sault Ste. Marie. It's at the border between Michigan. So we have Sault Ste. Marie, Michigan, and Sault Ste. Marie, Ontario. And that's how it looked during the summer. It looked very nice, but that's actually how it looks during the winter. So we have tough winters actually, and you can imagine from the other picture how high would be the snow on both sides of the roads when you drive. I have no conflict of interest related to this lecture. So the objectives of my lecture is like what early career is, and then I'm going to speak about what are the competencies required during the early career, and what are the approaches in order to acquire these competencies. And finally, I'm going to speak about work-life balance. So early career actually is basically defined as the first 7 years after completing training. So for example, if we have a resident or our residents, after finishing the residency training, the first 7 years, that's called the early career. This period is a period actually that you're gonna try to build yourself, try to build your academic reputation, try to start your independent clinical practice, and you need to consolidate your independent clinical skills with safe clinical practice, and you need to explore potential career paths. You're gonna do academic, you're gonna do private, you're gonna do community, you're gonna do military, whatever. And then you need to acquire communication and leadership skills, which is gonna be the next level after clinical training. And eventually, you need to establish what's called professional identity. And I'm gonna speak about this later on. So what are the required competencies in order to start your early career? First, the clinical proficiency. So it's here, proficiency is a keyword. You learned the clinical competencies during your training, but now, after starting your independent clinical practice, you need to be proficient. You need to perform things in a safely manner, and it needs to be evidence-based. So clinical proficiency, you need to acquire research and academic skills, and eventually you need to have leadership and communication skills, and you need to cover all of this again with ethical and professional behavior, because that's what's gonna make you survive, what's gonna make you keep your professional identity in the future. So in terms of the clinical proficiency, you need to go to higher level, which is mastery of common procedures, and you need to acquire progressive responsibility about what you're doing. You need to focus on safety outcomes, and all of your practice needs to be evidence-based. I really thank the Egyptian Urological Association, Dr. Murad. Now, I think we have Egyptian Urological Association guidelines right now. So this is going to be the basis for what's called evidence-based practice in Egypt. Research and academic skills. You already identified some during your training, but you need to, now you're going to start, you're going to be independent. So you need to foster your identifying clinical questions and research gaps, study design and methodology, data collection and analysis, writing manuscripts and abstracts, and then you need to identify which journal you need to target in order to publish your research, and eventually how to respond to reviewers. And during this process, there is very important thing, which is mentoring. You need, during your clinical and research practice, you need to have a mentor. And I'm gonna speak about the value of having a mentor later on, okay? Because having a mentorship, it's gonna improve your efficiency and improve your quality. In terms of the leadership and the communication skills, you need to identify how to lead multidisciplinary teams, because now like nobody is working alone. You know, we all work in multidisciplinary teams. So you need to identify how to lead multidisciplinary teams, how to solve the conflicts within the team, you know, and how to do team management, and how to delegate the authority and to who, because you need to identify accountable people in order to delegate your authority, and eventually you need to do strategic planning and goal setting. In terms of the ethical and the professional behavior, core ethical principles, you need to identify this. You need to identify, like you identified how to do, for example, consent and confidentiality when you are resident, but when you do this as principal investigator or as a team leader, you need to, you know, secure that this is done or always being done correctly. And you need to actually continue having ethics workshops and mentorship. So what are the approaches in order to obtain all of the previous things, you know? So I summarized these in these items. So first of all, funding. You need to, for example, in order to do research, you need to have funding, okay? In order to even to do a clinical fellowship, for example, as a Western qualification, for example, in Europe or in the States, you need to have funding. And that's a big problem for us here. And actually, I would have loved all of our residents to attend this session, because that's what's actually I'm gonna show you here how to obtain a fund in order to, you know, to fund your scholarship or a fellowship, for example. Second, it's about the fellowship. You need to have a fellowship trained. I did not identify the importance of having fellowship trained until I got outside. You know, we need to understand here that master and MD degrees are considered academic degrees, you know, in the Western countries. Here we consider, like, you know, if you go outside, for example, you know, and say, I have a PhD, okay? PhD is considered something that you had something academic. It doesn't mean that, for example, you had a board qualification. So board qualification, you need to have like accredited training, like residency. Here, even we don't have residence certificate. Like when you start a fellowship over there, or when you start a career outside of Egypt, you know, fellowship training is something very, very important and even very prestigious for you in order to secure early career. So I'm going to speak about this, speak about the importance of mentoring, speak about patenting. You know, like if you have an idea, like do you keep this idea inside? So as long as the idea didn't come from here on papers and did not get patented, you know, nobody will benefit from this idea. So we're going to speak about this. We're going to speak about how to build your personal identity and reputation, like how to do branding for yourself. This is very important word here, how to do branding for yourself, and eventually, while doing all of this, how to do or how to keep work-life balance. So, and here, I'm going to start with the research scholarships and the grants in order to obtain funding. You know, during this part of the lecture, I'm going to just give my personal experience. And I guess I have like a vast experience in applying for research grants and scholarships. I summarized almost all of the grants and scholarships that are offered by the American Urological Association, European Association of Urology, Indian Urology Society, SIU, and CUA, in order for us, you know, to identify what are the available scholarships that I can apply for. So unfortunately, not all of these scholarships are available for international applicants, and it's only limited scholarships that are offered for international applicants, and I'm gonna show you what are these and how to apply for it. So, for example, from the American Urological Association, the granting agency of American Urological Association is called the Urology Care Foundation. Urology Care Foundation offers multiple research awards and grants like this. Most important here is the Research Scholar Award. It's called the Urology Care Foundation Research Scholar Award. That's the only one that's offered for international applicants. So, and it's actually very competitive process. So you can imagine that the AUA offer one Research Scholar Award per year, and it's open for international applicants. You can imagine, you know, like how much applications they will receive internationally. And then, you know, in order to win this scholarship or this award, it's something prestigious, but it's something as well, it's gonna provide you with a fund. For example, here, It supports mentored research training. The target is clinical fellows, postdocs, early career faculty, duration 1 to 2 years, and they provide 40,000 USD dollar. And this fund is going to be matched by the hosting institution. So for example, if one of the residents here would like to apply for a fellowship, for example, in Europe, or for example, in the United States, and doesn't have fund, he or she can apply for this fund. Like 40,000 United States dollar, I think it's going to support him or support her during this fellowship. So actually, when I joined McGill University in 2014, I went there for like 6 months only. That's the fund that my mentor had, okay, and that's the fund that I was offered. But after these 6 months, I was supposed to go back to Egypt. But in order to survive, in order to continue, you need to apply for fund. I applied for this fund, and if you see here, it was very competitive process. You see that Dr. Nuruddin, you won this scholarship, or you won this fund from about 48 applicants from different parts of the world. But actually, this scholarship helped me to survive. So that's one of the important scholarships that any resident can apply for, and if you obtain it, it's something that's gonna help you maybe to obtain a clinical fellowship like what I will explain later on. So that's actually during our graduation, during the AUA, it was in San Diego, 2016. Second, the European Association of Urology have what's called European Urological Scholarship Program, or EUSB. So any resident would like to identify the potential scholarships, he or she can go to this website and identify what are available. So actually they offer what's called the clinical visit or clinical fellowship or 1-year scholarship. These are, sometimes there is something for professors, like, visiting a professor. I'm not gonna speak about this, but I'm gonna speak about the two scholarships. The clinical visit here, it's usually offered for 6 weeks to 3 months. They provide you like with 2,000 euros, for example, up to 4,000 euros. So you can go and visit an institution for 1 month or 2 months in order to obtain what's called mini fellowship. Or most of the time, this short visit, it's as a preliminary, step for having 1-year scholarship in order, for example, to have clinical fellowship, 1-year clinical fellowship in Europe, for example. And actually, that's what I did when I started my clinical fellowship in Greece. I was accepted for clinical fellowships through the Indian Urology Society and AUA, but I did not have fund in order to go to have this clinical fellowship. So what I had to do is that I applied for this one. I obtained it. It was like 30,000 euros, and it actually covered my 1-year fellowship in Greece. So that's one way to go in order to have fund if you would like to have a fellowship to be Western qualified, have fellowship in Europe, for example. That's the 1-year scholarship. And that's when I had my clinical fellowship with Professor Liatskos in Greece. And actually, this fellowship, this fund did not provide me the opportunity to have clinical fellowship only, but we won the best scholarship award during the AIU, and we had this in Amsterdam. It was 2022, after COVID. So the Indian Urology Society offer scholarships as well. So we can see here that there is summer student scholarship and international traveling scholarship. They offer 5,000 for a scholar to go and have 1 month visit. For example, I won this. I had 1 month visit with Professor Traxler in Paris, and it was a very good opportunity. You don't have to pay something from your pocket. It's all on the Indian Urology Society. SIU scholarships, there is training fellowships, and there is fellowship programs. I obtained this as well, and I spent 1 month in Asclepius Hospital in Barenbeek in Hamburg with Professor Andrea Gross, and it's a good opportunity as well. So these are the things that you can apply for and you can obtain in order to foster your career, okay? CUA usually do not provide, something or scholarships for international, but there is what's called the CUA SF SIU. So it's something combined between the CUA and the SIU. You can apply for this as well. I applied for this and I won it, and that was during the CUA 2025. I was fortunate to have one of our very nice colleagues here, Dr. Hazim. I think he's from Asyut, I think. From Asyut, and it was very good opportunity. So second, so now we finished how to obtain a fund. Now we need to move to the fellowship training. There are different fellowships offered, by the GRS, Indian Urology Society, SIU, European Association of Urology, American Urological Association, and COA. And we can apply, for, you can secure these fellowships through the fund that I explained before. One of the important things is that you need to be, in order to be Western qualified, you need to pass exams, So I encourage like all of the residents to try to go through the licensing exams. For example, we have the European Board of Urology here, and we have partnership with Egyptian Association, Urological Association. Actually, this was started by Dr. Ibrahim Mukhlas, rahmatullahi alayh, yani nad'u Allah wa rahmah. Well, actually, I was one of the candidates who benefited from this program, and I was one of the one who obtained this certificate. Again, now I'm going to speak about the importance of mentoring. So, in order to apply for a grant, in order to apply for a fellowship, in order to do research, in order to do everything, you need to have a mentor. That's very important. You need to have a mentor. Like to apply for a scholarship, they will ask you for a letter of recommendation. How can you get a letter of recommendation if you don't have a good mentor, okay? And you need to be very cautious when you select your mentor, because that's gonna be like lifelong relationship. It's not something that you're gonna do for a week and then you leave. No, there is usually mentor and mentee relationship that will extend over time. So it's important because the mentor will provide guidance, support, and help navigate the ropes of success. You need to seek out experienced urologists willing to offer advice and support. And I just need to explain here, you don't have to have this mentor locally. You can have mentor internationally. You can have virtual mentor. And now even robotic surgeries are performed, remotely, and you can have virtual mentor or virtual book proctor online. Patenting. Again, if you have an idea, you need to patent this idea. You need to get this idea out, write it on a paper, submit proposal and apply for patenting so you can obtain a patent for this idea. Actually, I had this very nice idea for a long time. There was no modifications for urethral catheters, so we came up with a catheter which has nano sensors to measure pressure and to early detect the infection. And after 4 years of work, we recently had this patent from the Saudi Authority for Intellectual Property. So it's important, if you have idea, you need to apply for a patent to patent this idea. Next, how to build your personal identity and reputation. How to do branding for yourself. That's very important. So to have a fellowship, you have a clinical fellowship. In order to be distinguished in at least one procedure, you need to be well known with this procedure. You do a research in subspecialty or certain topic to be well known on this. And then that's how to get specialization. But then after you get super specialized, you need to have visibility. How to have visibility? You need to go conferences like this. If you go a conference, present your work. That's how you get visible. You can have visibility virtual, actually, through the social media, through Facebook, through X, LinkedIn, we have YouTube, we have Instagram, and you need to create some sort of collaboration. You need to have partners, from different hospitals, for example, in Egypt, from different institutions, outside Egypt. That's how you create what's called partnerships or collaborations. And during all of this, as I mentioned before, you need to adopt professionalism during all of this, because without being a professional, you're not gonna survive. That's very important topic. So I'm actually gonna give some examples of young urologists here in Egypt who went through this process, and we all know them right now as they were able to brand themselves. For example, Dr. Shal, he's a very good friend, he had fellowship at McGill University, and then he came back here, he created the Urology, Mansoura Urology Academy, he's doing reach out, now doing different courses internationally. Some people will come from outside to learn here, Holib, for example. So that's a very good example of young urologist or early career urologist, who did something and did branding for himself. For example, Dr. Muhammad Kamal, he's from Al-Munufiyya University. He had the SIU fellowship for 6 months. He went to Mansoura, he learned at Holib, and then he came back. Now he's like a brand in bipolar Holib. Okay? Dr. Muhammad Nafa, He's one of the very nice candidates. You know, he went to have GRS fellowship with Kulkarni, and then he came back. He's now doing monthly workshops and disseminating the knowledge in Egypt. Dr. Wali Mahfouz, he had a fellowship at McGill in female urology, and now he's one of the figures in Egypt in this. I do think that these are very good examples to our young residents in order, you know, to identify how to start an early career. What is it? Okay. I'm almost done. So that's the last slide. During all of this, as I mentioned before, you know, you need to create work-life balance. Don't forget yourself. Don't forget that you have a family. Don't forget that you have friends, you know. Don't forget that you have yourself, you know. So, إن لبدنك عليك حق ولزوجك عليك حق يعني and go on, okay? Why it's not moving? Thank you so much.
Thank you, Dr. Yasser, for this comprehensive lecture about future of our young urologists. Now, we ask Dr. Ahmed Abu Zaid to present his talk about Optilome for recurrent urethral stricture. تفضل Dr. Ahmed.
Thank you. Assalamu alaikum. Today we're going to discuss, it is not a new technique. The Optilome has taken the FDA approval since 2021, but it is new in Egypt here. So it is a discussion about the Optilome and the first case to be done in Egypt here. Okay, we wanted to define the urethral stricture. It is the narrow segment of the anterior urethra. It is a process of fibrosis and cicatrization of the urethral mucosa and the surrounding spongiosal tissue, which is called the spongiofibrosis. The causes of the urethral stricture, of the anterior urethra particularly, we have the urethritis, gonococcal, sexually transmitted diseases. Also we have the lichen sclerosis, external urethral trauma, like especially the bulbar urethra, like falling astride or kicks to the perineum, penile fraction during vigorous intercourse. Also we have the iatrogenic urethral injury. It is one of the most common causes of stricture in well-resourced countries, accounting for 32% to 79% of all strictures. واحد من أهم الأسباب هو الurethral catheterization, followed by the transurethral prostate surgery, the long procedures, not using frequent lubrication. The most common sites are the pulmomembranous urethra, followed by the fossa navicularis and the penile urethra. Also, you may have a trauma by the using of ureteroscopy. By the beveled tip of the ureteroscopy, you can injure the fossa navicularis if you're not entered well. We have also the urethral injury during the penile prothesis implant. And this is the AAU classification according to the degree of the urethral narrowing. It starts with 0, there is no stricture at all, and end with 5, complete obliterative stricture, there is no urethral lumen. This is the algorithm of the urethral stricture management according to the AUA 2025. But we are, and although the golden standard for urethral stricture is the urethroplasty, but we have to first review this paper about the reconstructive urology power. This, the areas in red, this is the number of the reconstructive urologists and who are doing urethroplasty. In the red, there is no urethroplasty at all in these areas in the United States. While in the yellow one, only 1 to 4% of urethroplasties are done in these areas. So we have a deficiency in the reconstructive urologists who are doing urethroplasty all around, not only in Egypt. Also, we have to review this paper from the urology annals. The most common procedure used to manage the urethral stricture were visual urethrotomy في 82% وcystoscopy and dilatation في 62%. Everyone is trying to avoid the urethroplasty as much as he can. The urethroplasty, the surgery, is the golden standard for management of the urethral stricture, but we have certain circumstances that we tend to use the minimally invasive techniques. Due to the shortage in the number of the urethroplasty surgeons and the complexity of such cases, most of the surgeons tend to use the minimally invasive techniques for management of the urethral stricture disease, either to lack of referral centers or the patient is unfit. يعني ممكن يكون ما عنديش جراحين في المنطقه بتاعتي اللي هي موجود فيها التريتوري اللي انا موجود فيها بيشتغلوا يوريثروبلاستي، او ان المريض نفسه he is unfit for urethroplasty. فساعات انا بلجا ان انا استخدم حاجه minimally invasive او حاجه اقل burden على العيان نفسه. What is the suitable solution؟ لما انا خلاص انا قررت ان انا اعمل حاجه minimally invasive للبيشنت، ايه هو السيوتبل سوليوشن بتاعي اللي انا اقدر اعمله؟ بخش بقى في دايلما بقى اللي هو اعمل له دي في اي يو، اعمل له دايلاتيشن، اعمل له دي في اي يو combined by intralesional injection. فهي دي الاندسكوبيك دايلما. تمام؟ طيب بالنسبه للدايلاتيشن، الدايلاتيشن كان في الميتال ساوندز بس محتاجه هاي ليفل اوف اكسبرت. تمام؟ والهاي بريشر بالون هي السيفست ميثود في الدايلاتيشن. برضه في هنا البيبر دي من كانت في جامعه المنوفيه الاشتراك مع الدكتور فيصل الهاجري، هي combining DVIU with intralesional tamoxifen injection. Also we have the injection of platelet-rich plasma combined with dexamethasone and DVIU in Sohag University. But we have to know the indications of the DVIU. مين اللي اقدر اعمله DVIU ومين اللي ما اعملوش. فيكون واحد يعني 1 to 1.5 centimeter structure, not good for less than 15 French structures. It will be very tight. Single structure, not multiple structures. Better in bulbar more than penile urethra. First attempt carries the best result. ودي اهم موضوع فيهم. First attempt carries the best result. Different energy modality, we have the cold knife, the Holmium YAG laser, and bipolar. But also, although it is so simple technique, but carries a lot of complications, like the recurrence, which is the most common, and you may have an erectile dysfunction. So, decisions are more important than incisions. So I have to decide who is the candidate for minimally invasive technique. Today الاوبتيليوم هو الفكره كلها ان انا بحاول ابريك السايكل نفسها. انا بعمل دي في اي يو للعيان او بعمل له انتراليجنال انجكشن او مش بعمل له، لكن بيحصل تاني ريكورنس بعد فتره قصيره او طويله. فهي عباره عن دايلاتيشن، بيحصل تيشو جروث، هيلينج باي فايبروزس، فيحصل ريستركتشر اجين، فري تريتمنت اجين. احنا هنا بنتكلم على الاوبتيليوم نوت ذا يورولوم، ده عشان بس تشابه الاسماء. اليورولوم ده كان تكنيك زمان قديم موجود، بطلوا وتوقفت استخدامه خالص من 2013 لان عمل سيفير كومبليكيشنز زي ما حضراتكم شايفين. الاوبتيليوم ده الموضوع بتاعنا النهارده فور ريكارنت يوريثرال ستراكشر. الميكانيزم اوف اكشن بتاعته هو عباره عن ان انا بعمل كومبينيشن ما بين الدايلاتيشن باستخدام البالون، هي هاي بريشر بالون، تمام، و ريليس اوف ذا دراج ان ذا ستراكشر سايت. عشان كده هي اسمها الاوبتيليوم ذا دي سي بي ذا دراج كودد بالون. الميكانيزم اوف دايلاتيشن بيعمل كراكنج في الميوكوزا، تمام، بيعمل كراكس في الميوكوزا فبيوسع الايه الستراكشر نفسه. then بيحصل ريليس للدراج اللي هو اللي موجود في الكبسول نفسها اللي هو الباكليتاكسل. الباكليتاكسل ده كيموثيرابي معروف بانه ليه انتي بروليفريتيف افكت، زائد ان هو هيدروفوبيك، فما تقلقش ان هو يحصل له ووش اوت مع اليورين ومع اي حاجه ثانيه. وهو لايبوفيليك فبيخش بيبقى deep inside the cracks you made by the dilatation inside the structure. دي روبست ستادي اتعملت على 127 patients enrolled in 22 sites in the United States and Canada. لقوا في significant improvement in the IPSS, average Qmax, and the BVR were maintained at 2 years. And there is the most important thing is the freedom from repeated intervention. It was significantly higher with the Optilume لأنه كان هو بيعمل مقارنة ما بين الأوبتيلوم نفسه وما بين الدايلاتيشن العادي والايه والدي في اي يو. السبيسيفيكيشن بتاعت البالون نفسها، البالون اليومن في 18 فرنش، 24 فرنش، 30 فرنش and 36 فرنش. fully inflated balloon length 3 cm for treating structure less than 2 cm, 5 cm for structures less than 3 cm. جايد واير compatibility مع اي جايد وايرز موجوده معانا. Single use, you cannot use it again because it will lose the effect of the release of the drug. Latex free. Inflation device provided بيجي مع الباكت نفسها. For use with rigid or flexible cystoscopy can be used with fluoroscopy imaging or direct visualization. I have the honor to attend and assist in this case with Professor Sharif Murad. This was the first case to be done here in Egypt with Optilume. He is a 55-year-old gentleman presented with weak stream and post-micturition dribbling along with recurrent UTI. Ascending urethrophy shows stricture at the bulbar urethra about 2 centimeters. There is a history of previous DVIU 1 year before the operation. Here we have a video presentation about the operation. We do the diagnostic urethropy. We stop at the structure site. Then we put a guide wire. This is the setting of the Optilume. This is the Optilume device. You have to handle with care. This is the balloon up here. Avoid to touch it or rub it or even lubricating it. The inflation device come with the Optilume. Then we try to adjust the balloon inside the structure. Once we get sure that it is inside the structure, we begin to inflate the balloon. We have to inflate it and to reach the pressure with the pump to 10. Like we see, we have to raise the pressure, raise the pressure, raise the pressure till we reach 10 millimeter mercury. And we leave the balloon inflated for 5 to 7 minutes. Here is the balloon. So you see that the inflation make a dilatation of the structure. Then immediately after complete inflation, the backlet axle start to be released inside the stricture site. Like we mentioned before, we leave it for 5 to 7 minutes. You can remove the catheter after 1 week. This is enough. Some important precautions before you use. Try to minimize handling the balloon. Do not touch the balloon. It's very sensitive. You may disrupt the drug coating it. Avoid webbing or lubricating it. Do not perform retrograde urethroplasty immediately post-operative or intraoperative because it may wash out, because of the dye, it may wash out the effect of the paclitaxel. There is a study stated that you have to examine your patient well, because if he is sexually active and he desires for fertility, you have to ensure that he does not have any fertility trial before you do a semen analysis, because they did a semen analysis for patient after 6 months and they found the paclitaxel inside the semen. So you have to ensure that your patient do a semen analysis if he desire any fertility after Optilium. That's all. Thank you.
شكرا دكتور أحمد. Any question from the floor? Mike.
Not yet. But after removal of the catheter, he now has about 4 months. There is no.
A blue curve for this patient, blue curve only, given before and after?
No, before it was less than 12.
Yes,
It
after?
was less than 12. After that it was 23.5.
Yes.
There is no symptoms at all.
Only one case, yes.
This one case, because we have some limitations that the device is very expensive, and there is no price for it.
There is a strict indication for use of Optilium.
It is made mainly for the recurrent urethral stricture. It gives you a good opportunity as a second trial post DVIU, and all the robust study, all the patients, the inclusion criteria have previous DVIU.
شكرا.
Thank you.
Now we close the session. Any question beside each other to start in time the second session of our meeting. Thank you.
Thank you, Dr. Ahmed.
Thank you, Dr. Hassan Abdul Latif. And may I call on Dr. Ian Pierce and Dr. Sam Nouer to come to the stage, please.
Just a few questions about
Okay.
Optilium. I will change it from a question to point of view.
Okay.
So what's your opinion if we can use Optilium in primary cases, not recurrent only? This is number one. Number two, if we use it immediately after DVIU, it will help to improve the outcome. Maybe it will improve the urine flow. It will decrease the bleeding, and also it will advance the dilatation for the maximum. Usually we use it for some cases. Immediately with the DIVU, we put the Optilium and we get better result.
Okay. I'm depending on the robust trial. Here, all the inclusion criteria of the patients, they had at least one DVIU prior to the Optilium. So it is mainly used on the recurrent strictures.
Due to economic,
No. This is the study, not for the economic. This study was conducted in the U.S. and Canada, not here. But here, economically, would be very difficult because the device is very expensive. Thank you.
Thank you. شكرا دكتور أحمد.
Thank you. Just
Well-
one
well-
last comment and last question regarding the DVIU pre-optilium. We have some experience with that, and we do usually serial dilatation before optilium itself. So we do serial dilatation, we have initial good result and less recurrence rate. And the most important, I think, for optilium is giving the patient all the precautions before and the protected sexual intercourse, because it can extend up to 3 months with the drug released with the urine. Thank you for your presentation.
Thank you.
Thank you. Now we're starting the second session, and this is a very new collaboration between the Egyptian Urological Association and the BAUS, the British Association of Urologic Surgeons. And we want to announce about the collaboration of the British Egyptian Medical Association of Urology, and starting this collaboration with this meeting. Actually, it's a very prestigious and important collaboration with great opportunities to our young urologists of working and studying in the UK as well, and participating in the joint scientific projects between the two societies. I want to introduce Professor Ian Pierce, international renowned andrologist and urologist. He's one of the first surgeons in Europe to adopt the infrapubic approach of inflatable penile prosthesis. Also, he's the president of the BAUS, and we are very pleased to have him in Cairo this year. Also, I want to introduce Dr. Hussam Nouer, the British Egyptian Medical Association chair, and he is also the committee secretary of the BAUS and fellow of robotic surgery in the University of Wales in the UK. And also I want to welcome Dr. Ahmed Al-Ghunaimi, or Ahmed Ghunaimi, is chair of scientific committee of the BIMA Urology Consultant of Urology at James Cook University Hospital. Actually, Dr. Hassan Abu Anin, the president of the EUA, had a visit to UK in June, and he met with the BAUSA offices, and he had this kind of collaboration starting there, and he will give us a note about his experience with this collaboration.
Thank you, Dr. Sharif. Good morning, everybody. Of course, it is very good to have our brothers migrating to another countries. And I have a very unique experience in meeting with them during the last pause when they nominated me to receive St. Paul Medal as the career of urology over years. I would like to welcome Professor Ian Pierce. He is a very well-known figure in practice of urology. In addition, he is a master of political reaction with all the colleagues, especially for the Egyptian group. I was admired from the collection of number of doctors migrating to there and having very good positions everywhere in UK, in addition to other areas in Europe. But it was a unique experience to have them all together to the limit that they make a union or sort of association of Egyptian urologists there, including in the British Egyptian Medical Association, the section of urology. Of course, this would be a good landmark of how our fellows who migrated to another countries will do very good things, very good reputation, and many of them now are chairs or co-chairs or senior professors and senior consultant everywhere in UK. We sit together and we make an agreement of dual experience exchange between Egyptian Association of Urology and the British Association of Urology in exchanging knowledge, exchanging training, and of course still we need just to refine and tuning the final agreement of how many of our urologists will go there for training and how many of British urologists will come to us. And of course, in a couple of days, we will finalize this agreement, inshallah, and it would be very fruitful for both sides. Of course, I would like to welcome all the group migrating birds from Egypt to UK to come back, as well as from the other countries, and a special thanks to Ian Pierce and the PAUS group. Of course, we would like to listen to the group of Egyptian urologists living there and give us what they thought, what they feel, what they did, and what they can give us from the previous experience of leaving their home country and the practice on the other. Of course, they are not leaving. They always are in the heart and mind all the time, and they have a very strong link. And this is one of the fruits of the links that we have to come back together at such occasions, and of course will help each other. I don't like to kill the time of the session, and I just give the microphone to Professor Ian Pierce to give a few words.
Thank you very much. It's a real massive pleasure to be here. Thank you very much for inviting me to your wonderful city and your beautiful country. It's been over 10 years since I had the pleasure of being in Cairo, so I'm very delighted to be back amongst friends, amongst colleagues, and I hope to meet very many of you in the next few days. Thank you so much.
So we start now with Dr. Hussam Nouer giving the introduction about this new collaboration.
Assalamu alaikum. Okay, next. Professor Abul Aleen, Professor Murad, it's a pleasure being here, dear attendants, mentors, colleagues and friends. It's a pleasure being among you here in Egypt. I here present myself as Hussam Nouer. I'm a urologist living in the UK. I'm currently doing a fellowship in robotics in Cardiff University, as well as being the chair of the BIMA Urology, which is the British Egyptian Medical Association of Urology. And I'm also privileged to be the secretary of the BAUS SSTU committee. And here we start. So I'd like to start by giving an introduction about the BIMA, or the British Egyptian Medical Association, who we are. So the idea started about 2019, where a few consultants, Egyptian consultants in the UK, sensed that the number of Egyptians living in the UK is increasing. In 2019, there was about 9,000 Egyptian doctors living in the UK, which rocketed around COVID time to reach about around 12,500 doctors. An idea about the board of the British Egyptian Medical Association. You can see here there is ENT, and we have anesthesia as well as pain consultants. Amongst the figures of the British Egyptian Medical Association, we can see a president of the Royal College of Physicians, a vice president of the Royal College of Obstetrics and Gynecology, as well as the ophthalmology. So, what are the general aims? We're trying to provide a professional support network for Egyptian doctors in the UK, strengthen the communication between the people living in the Egyptians in the UK and the community here in Egypt, trying to support the healthcare system as much as possible, create opportunities for the next generations who are considering moving on to the UK, offering a healthcare advice for Egyptians, as well as establishing like regional hubs in the UK and elsewhere where we can support each other. The main domains that we're working on is mainly working in partnership with the UK NHS trusts, where we support the Egyptian doctors across the different trusts, helping to recruit more Egyptian doctors if we know that there are any opportunities where our colleagues could fit, and trying to build Egypt-UK collaborations in different subspecialties. In terms of training, we're trying to, in regards to in Egypt, we're trying to do a lot of courses here in Egypt. Last month we had 2 courses held with the anesthetics and pain departments in Ain Shams and Cairo University. In the UK, we're trying to continuously offer the courses which help develop the personalities, help make the doctors ready for the exams, and etc. So far, there has been some key achievements, including recognition by the General Medical Council in the UK and the British Medical Association. We have been actually very active during the COVID with the COVID-19 inquiry. We've launched an IMG support initiative, which has later been adopted by the GMC. We're also trying to have active branches in different subspecialties as well as different career stages. So these are the things that we've done so far. We've been successfully running periodic webinars, which are quite crucial. If you're working in the UK, you probably know how these are essential to know, especially when you're first introduced to the UK system. There's a lot of differences from living here in Egypt, such as job planning, how do you do the job planning, pension, immigration, etc. We've been supporting doctors facing GMC difficulties. A few, I wouldn't say a lot, a few doctors have been reported to the GMC due to unawareness of how to work in the UK. We've been trying to get involved as much as possible. We've successfully launched 11 specialty groups, including, of course, the urology, which has helped in passing the exit exams in the UK system. We've been holding regular general assemblies, and the last one was in October 2025, and we've also held specialty conferences. One of the most prestigious events we've had actually was a webinar for the Caesar portfolio, which is the non-training scheme to be a consultant, and it was an online session where we had over 900 candidates attending. So this was the General Assembly, and we try always to, I'm trying to show you our work as much as possible to have an idea and sense our presence in the community in the UK. I'd like to introduce next my colleague and friend, Dr. Ahmed Bonaimi, to speak in depth more about working in the UK. Thank you.
Thanks, Hussam. Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks everyone for attending this session, and thanks you for the BIMA and Egyptian Association for inviting us for this session. So they gave me 15 minutes to talk about everything related to working in the UK, so I'll be as quick as possible. First of all, my name is Ahmed Bonaimi. I'm one of the assistant lecturer of urology in Manufacturing University, which I'm proud of. And I'm now working as a consultant urologist in James Cook University Hospital in Middlesbrough, UK, and I'm the head of the BMI Urology Scientific Committee. So first of all, to work in the UK, you need to have first the General Medical Council, the GMC registration, along with a job offer. So we'll talk about the GMC. We'll talk about the GMC registration and job offers, how to have them. For having GMC registration, simply, you need to have a proof of English proficiency, either IELTS or OET, along with one of the following. The PLAB examination, which I will not talk about a lot because it's more or less basic examination for mainly for the newly graduates, and it doesn't have a lot of impact on urology. More importantly, the MRCS, the FRCS urology exam, we'll talk about them now. The others, like the MTI, the sponsorship route, and the ISTP. To speak about the urology exam, the MRCS and the FRCS urology exams, you have to register with one of these 4 colleges. For the MRCS exam, we know that they have 2 exams, the written and the OSCE part. The price is down here if you are interested. The idea is the MRCS exam is mandatory now for having training in the UK. It's mandatory to have even the FRCS urology examination. So it is, if you want to work as a urologist in the UK, you have to have MRCS anyway now. For the FRCS urology exam is the exit of training exam, 2 parts, MCQ and Viva exams, and this is the cost down below, £1,900, and it is that one of the mandatory requirements for exit training and even for the portfolio pathway. There is no FRCS International anymore from December this year. I'm sorry. But this, so if you have to, if you want to have the FRCS oral exam, you have to have MRCS and to have to work in the UK. For the other routes of registration other than the exams, we have the MTI or the Medical Training Initiative, which is temporary registry or temporary work permit in the UK for up to 2 years. Before it was, you have to leave the UK to change it to another job, but now it can be changed easily. The other one, GMC sponsorship, it's more related to, sponsored by the trusts in the UK and gives you more long-term professional. These are the list of the hospitals which gives the sponsorship, so you can have a look on the website of the GMC if you are interested. So this is the first part, the GMC registration. The second part is to find the job offer. To understand the job offers, first of all, we need to understand the types of jobs of urologists in the UK. We have either junior or senior jobs, the junior jobs, the training or non-training jobs, and the senior jobs will be the jobs that you can work independently, a consultant or SS jobs. To make it easy, it's either training or non-training or a consultant. So as a training job, you have to have that training, the ST training in the UK. After that, you will be registered in the GMC registry as a register in the GMC, and then after that you can apply for the consultant jobs. For the non-training jobs, a lot of jobs, some like SHO, LED doctors, trust grade doctors, or clinical or research fellow, or other SS jobs. These are the non-training jobs that most probably anyone from Egypt can join as a first job. Then to work as a consultant, there are two types of consultants in the UK, either substantive or locum consultant. Anyone with good experience can work as a locum consultant. It doesn't need anything other than the GMC registration. But as a substantive consultant, you have to be on the GMC registry. We'll talk about this later on. So these are some websites to have a job offer. You have here the NHS jobs, the track jobs, the BMJ careers. These are some healthcare agencies as well can find a job for you, and then for free as well. There are two main types of work visa in the UK. The T5 visa is a temporary one for one or 2 years. It doesn't lead directly to indefinite leave to remain, but for the T2 general visa, which is called now the skilled or health and care worker visa, it's longer term employment and can lead after 5 years to indefinite leave to remain. I'll talk now about the training pathways in the UK. So we have to work as I said before, as a substantive consultant, you have to be on the GMC registry. To be in the GMC registry, you have to be either through the CCT pathway, which is the completion of training, certificate of completion of training, or the CSER pathway, which is called now the portfolio pathway. We'll talk quickly about both pathways. The foundation year 1 and 2, these are our MTS, okay? The CT1, CT2, this is the training, the core surgical training, and this is mainly for the ones who didn't have more than 5 years of surgical training. After that, which is most probably the pathway that most urologists from Egypt will go if they want to have the training, is the ST3 training, ST3 to 8. After that, you will gain the CCT and be in the specialist registry. So the question is it easy to secure national training number to have the ST training? We all know the answer. It's nothing easy in this world anymore. So why it's difficult? Because it's very competitive. So in 2025, we have every 4 jobs, we have only 1 accepted. So 25% of the applicant accepted to have the training. But we are not, it's not impossible anyway, but we are not the worst. So if you can have a look on the cardiothoracic, every 45 jobs applicant, you will have one. And the neurosurgery is slightly better. But again, we are not bad, it's 4.6 to 1. So what are the requirements to secure the national training number in the UK? First of all, to have medical qualification, the GMC registration, the logbook and surgical experience, the MRCS exam, and evidence of research, audits, QRP, quality improvement projects, leadership, teaching as a point system. I'll talk about this now. And then after all of that, to pass the interview. So the Oriel is the system for the training application. It's a website. You can have a look and see how they give you the markings. So first of all, you do the self-marking. I'll show you now the 23 questions that you go through. It's a very comprehensive one. And then after that, if you above 50, some special number of points, like this year was 52 points, you'll be shortlisted for the interview. After the interview, you will, if you are successful in the interview, you will go to ST3. So this is, for example, this year, the ST3 2026 application is open now, and then you can have a look on the website. This is a point system, 23 questions. You will put your points, and then after that, long listing, short listing, and then you have the interview. These are the 4 stations of the interview, 15 minutes each. Then the question is, can you apply directly from here without working in the UK? It's yes, but it's a small yes, I'm afraid. So why? Because it's very competitive. You will have better opportunities if you apply it after working in the UK for 1 or 2 years or even less. So after securing the number for the national training, you will have the rotation. So the rotation is moving from one hospital to another. So for example, this is the northeast rotation, 5-6 hospital, the same here for London, the same here for the east of England. You will not work in one hospital only, you'll work 1 or 2 years, or even from 6 months to 24 months in one hospital, and then move to another hospital. And after all of that, after the 5 years of training, after finishing the FRCS Urol exam, you will have the CCT. So this was the CCT. The other way is for the non-training jobs, is what's called before the CSER, Certificate of Eligibility of Specialist Registration, and now it's called Portfolio Application. So this is basically for anyone who is not in training can apply on this. So the idea is that you take the boxes to show the GMC that you are eligible for the specialist registration like the trainee. The requirements, it's evidence through 5-6 years. You have academic and the clinical evidence, the same like the trainees are doing during their ST training. The work-based assessment, everything online, the application opening is free, and then you have to pay 1,850. And unfortunately, if it's not accepted, you have to pay again and again. This is the evidence of summary, the summary of evidence that you may need for the CSER application or the portfolio application. So is there any effect for the evidence from Egypt? Again, yes and no. It counts mainly if it's well organized, and be smart in putting the evidence. Yeah, don't lie, because this is not good. And it can't be your primary evidence. It can be complementary to the evidence that you have in the UK. But we can use here the audits that we have. So if you've done any audit here, so that will be great. E-logbook from here, definitely. The leadership, if you have any leadership role here, and research, publications, QIPs, these are the main things that can help in the application. So these are the main differences between both the training and the portfolio pathway. It's بالضبط عامله زي نائب الجامعه والنائب الفيزيتور. تمام؟ التريننج ده نائب الجامعه. highly structured training, pushed by everyone. You have to finish it at the end of the training. But the other one, the non-training, the portfolio pathway, it's self-directed. If you didn't do the job, no one will tell you to do the job. So you have to make sure that you are ticking all the boxes. So I'll talk quickly about the fellowship opportunities in the UK. Professor Yasser Nuruddin made it easy for me actually. He spoke about the fellowships not in the UK but in general. Again, it's not impossible to gain a fellowship in the UK. However, to understand what the fellowship is, it's a program of intensive training, the chosen subspecialty, usually completed after or at the end of training. So, do you need to consider fellowship? Again, I will say yes, but why? The research, there is evidence that fellowships are very important, are good in decreasing the mortality and complication rate. It's no difference in mortality and complication rates between the senior surgeons and the fellows. And when the Royal College did this survey 2017, 2018, between the fellows, they found that most of the fellows are doing the fellowships to be better surgeons, to have better training, and all of them did say that it's worthwhile, and they were well supervised, changed their practice, achieved their set goals, again secured the consultant job after having the fellowship. So everything has pros and cons. We know that the fellowship is important to have good experience, protective theater time, academic and research jobs. However, it's temporary and fixed term, not more than 2 years in most places. Competition with trainees who are applying for the fellowships, who are inside the department whilst you are doing your fellowship. Financial and social relocation costs, definitely. If you are moving from one place to another, lower salary. If you are not doing on calls, the salary will be less when you have fellowship and not counted toward the specialist registration. So, what fellowship that you can apply for or you should search for? Attractive subspecialty that you like, with clear learning outcomes, clinical and research perspectives, and a balance between the service and training jobs in the program. When exactly? Most of the fellows are taking the fellowship at the end of their training, ST8, ST7-8, or after the exam if you are not in training, or after CSER if you are not in training. Where exactly? So you have to have high volume center with capable mentors, can give you the good experience and patient to teach you, to feel safe under their supervision with constructive feedback and good program. The types of the UK fellowships, we have the RCS Royal College recognized fellowships, which are the most prestigious fellowships. You can have a look on the website of the BAUS, or the BAUS recognized non-RCS recognized fellowships, and there are some local fellowships as well in some trusts. There are some challenges regarding having the fellowship because it's less opportunities, lower number of jobs, high competition. You're not the only one. Teresa spoke about this. But again, it's not impossible. This is an example of the fellows who had, the Egyptian fellows who had the fellowships or having now their fellowships. So you may have some familiar faces here in different subspecialties, robotic fellowships, functional urology, upper tract, lower tract. So this is an example of one of the functional fellowships, the outcomes. So you can see here the difference in the starting and the end level of the training after the fellowship. Not only clinical, but a lot of courses, audits, information leaflets, publications, presentation, teaching. It's not only clinical work. I will not talk about this because Hussam will kill me now. We don't have a lot of time. But in general, it's not impossible. This is our fellowship. If you are interested, please message me. It's on the website, the Functional and Reconstructive Fellowship. And as a key fact, some of the key ways that you can help you here in Egypt, up-to-date CV, go to e-logbook, update it as regular as possible. Good news is that there is still significant demand for urology in the UK. Be flexible for the job type, and very important to have the good networking. And thank you. This was the last picture with Professor Hassan Abul Anin in Manchester this year. Thank you.
Thank you, Ahmed. Professor Pierce, I hope that our young urologists, to whom this session is mainly dedicated, to get benefit of all these presentations and to follow how to apply for fellowships and even observationships, as Dr. Ghanimi and Dr. Nouir explained to you, and also Dr. Yasser Din also gave a very good introduction for this. I hope you continue on following this and keep in contact with them, please. Dr. Pierce.
Thank you. Assalamu alaikum. Good morning, everyone, again. I've been asked to talk about bridging borders with international societies, but first of all, a couple of thank yous. Of course, thank you to the Scientific Committee for inviting me. Thank you all for being so hospitable. I'd like to spend a special thank you to my friend Hossam Nouir, who invited me through BEMA and, of course, through the EUA. So it's a real pleasure to be here. First of all, I thought, well, why bridge? Why do we need bridges between borders? And that made me think, what is a border? And we know of borders, they're lines of separation. We're used to seeing international borders between countries. We're looking at boundaries between different specialties, for example. And I think what they do is they serve to limit, don't they? They serve to protect us. And they create our comfort zone. So if we think about that, borders feel that they might be good. So why should we bridge them? But I came across this quote by a man called John Ashraf, and his pseudonym is the Brain Whisperer. Who wouldn't want to be known as the Brain Whisperer? What a great alter ego to have. And he said this about comfort zones. They're beautiful places, but nothing ever grows there. Now, whilst I don't necessarily agree with that, what I would agree with is that to have exceptional growth, we need to move outside of our comfort zones. We learn much more by being outside our comfort zones. So what that really means is that it's not why should we bridge, but actually why not? Why would we not build bridges between communities of like minds? And so that's really the position I'm thinking of. So when I think of of everybody here in Egypt and their Urology Association, what can the British Association offer you? And I think the first thing is it offers the hand of friendship, and the hand of true friendship. And that friendship is based on equality, on reciprocity, mutual benefit. So it isn't based upon one partner gaining more than the other, but actually an understanding that there will be mutual benefit to both of our societies and the members of both of our associations. And fundamental to that is that we have a shared ethos. We've got the patient at the very center of all of our activities. And I think in that respect then, the EUA and BAUS have a huge amount to offer each other. BAUS is obviously the National Association in the UK. It was founded literally within 2 years of the EUA. So in that respect, our organizations are brothers and sisters, aren't we? We are sibling organizations. We've grown up together, and now we're approaching sort of 70 to 80 years in existence. We've been around the block together. We have approximately 2,500 members, of which 148 members overseas, with a similar number overseas of retired colleagues and across 30 countries. So whilst we are worldwide, the majority of our membership are based in the UK. And we also have an initiative called Urolink, and if you haven't heard of that, this is our sort of an initiative within UK urology whereby our colleagues go out and mentor, they train, and they help to educate local groups of urologists in Africa, places like Malawi. So, and we're very proud of that legacy that has created. As an international member, and of course everybody in this room is eligible to join as an international member, that's 205 UK pounds, which I think at the current rate is around about 12,000, 13,000 Egyptian pounds, which I think is a lot, and I'm currently working on that to try and make that a little bit more, less eye-watering than it is. But what do you get for that? You get full access to the BAUS website, you get a couple of journals, Journal of Clinical Urology and the British Journal of Urology International. The Journal of Clinical Urology, which is owned purely by BAUS, is actually very similar in its orientation to the Egyptian journal. I've had a look at that this morning. What a fantastically clinically relevant journal that is. And actually the JCU is very similar to that. So it's not really basic science, it's very much what all of us do on a day-to-day basis. And of course you can get event discounts and access to webinars. And webinars, of course, they're the ultimate thing, aren't they, for education, because they take away all the boundaries. It doesn't matter if you're thousands of miles away or 2 or 3 hours time difference away. Everybody can join in. If you're a trainee, that gives you access to more academic literature, of course, access to educational materials. And we recently did a scoping exercise of all of the educational materials on our website, and we had over 25,000 offerings. Now, nobody's going to get through all of those, and we've been through systematically with a group of colleagues to look at the most relevant, most up-to-date, and we've cut that down by 75%. So everything on there is completely up-to-date and state-of-the-art, and that ranges from consensus documents to guideline documents to review of guideline documents. So there's a huge amount out there. It gives the trainees access to courses, both online. The scientific base of urology course, which used to be held in person in London every year, is now online. And it also gives access to mentoring and networking. And I think we all know across the world how important that is. It's already been mentioned earlier today. And of course, there is an event later on early evening where this will be the focus. So mentoring and network, absolutely vital to all of our careers. Nobody in this room, I think, has got this far without any level of mentoring. What about those consultants or residents, the people who are at the top of the game? Well, again, you've got access to academic literature. You can get involved in educational material delivery. In other words, if you've got an idea for a webinar, and perhaps that's something that we can collaborate with, then we'd love to host that. We'd love to make sure that that happens and that both associations can benefit. You can get involved in, obviously, in the meeting. Again, there's more network. And it's a real personal pleasure and professional pleasure for us to have awarded the St. Paul's Medal to Hassan early this year. And this is UK Urology's highest accolade for an overseas colleague. So that was an amazing opportunity for us to host Professor Abel-Anin in Manchester this year. What does a collaboration between associations look like? Well, actually, I don't think there is a recipe. There is no defined criteria. It's essentially tailored for the specific collaboration between the two organizations. So whatever works between the two organizations, that can be achieved. It's got to be flexible, and I think just as our associations have grown over the last 7 or 8 decades, so too would any collaboration. And we are very proud of our significant collaborations across the world that are already in existence, and we're absolutely looking forward to furthering our collaboration with the EUA. What does that look like? How do we build that bridge across those barriers that we talked about earlier? Well, it could be meeting participation, attending a meeting. Attending a meeting in itself is a fantastic opportunity to meet new people, to listen, to participate, and that is really invaluable. Why not see a designated lecture or a designated session just like this? Wouldn't it be great if we saw in the future that when colleagues in the room came to the BAUS meeting, the next one of which is in London, if there was a dedicated session, a dedicated BEMA and BAUS and EUA session? Wouldn't that be fantastic? Hassan talked about a memorandum of understanding, and again, this is within our gift to dictate what is included in that MOU, and I look forward to our association signing that. We could expand trainee collaboration, I'll talk a bit more about that, and of course, joint educational content. So, just to summarize this before I go on to my next talk, BAUS is extremely keen to collaborate. Everybody needs good friends. Everyone needs a fruitful friendship. And I think it's in our gift to design what that looks like, to make sure that everybody benefits, everybody wins. So therefore, different models are possible. It doesn't matter what friendships look like and agreements look like elsewhere. It's what matters between the two of our associations that count. And as we continue to grow over the next 70 or 80 years, we will obviously see a joint evolution of our friendship. So I very much look forward to that. Thank you. I'll just move on now to cross-border academic collaboration, so a little bit more specific. And what is the aspiration? I think the aspiration here should be that we should facilitate collaboration at the desired level. But what does that mean to people? the desired level might be different from my perspective compared to somebody else's perspective. So what does it really look like? And I think the reality is it can look like anything at all. It doesn't matter what you want, the level of collaboration we should be able to deliver between the two of us. So whether you want I did supposed to say something else on there, but that hasn't come through. So any level of collaboration I think is possible. And these are not defined, I've just pulled these out of the air to sort of illustrate what could be achievable. So the sort of entry level of collaboration might just be access to literature. All of our journals combined together, so each of us can have access to all of that. And this is Professor Rakesh here. He is an academic urologist at Imperial College, and he is the surgical specialty lead for urology, which is a joint appointment between BAUS and the College of Surgeons. And what this role is, along with his 9 associates, is to be able to be a port of call for anybody who is interested in academia or interested in promoting their research. And that could be right at different levels. It might just be somebody who's got an idea and thinks to themselves, I don't really quite know how to get that off the ground. Rakesh will provide that with his associates. He'll provide advice, mentorship, tell you what to do, where to go. It could be at the other end of the scale. You've already started a multi-center collaboration, but you've hit a stumbling block. How do you get past that? And again, that advice will be forthcoming for all of our members. So Rakesh is providing a really great steer to ensure that everybody has access to some level of advice and mentorship. What does level 2 look like? Well, this could be something a bit higher on, couldn't it? A journal reviewer. All of our journals we know are looking for good peer reviews, good peer reviewers. And one of the great things about being a reviewer is that when you read other people's offerings, other people's manuscripts, it allows you to pick out those things and think, actually, doesn't that look great? Wouldn't it be brilliant if we could do something similar in our institution? But equally, it allows you to think about things more critically and say, that's a good project, but perhaps if they'd done it this way, it may have been slightly more robust. So it's a fantastic learning opportunity being a journal reviewer. Abstract markers. We know, don't we, anybody who's been to a meeting, that fantastic meetings like this one only happen when you've got good colleagues looking through multiple abstracts that have been submitted. Why not put yourself forward to be an abstract reviewer? I know certainly for our annual meeting, we have upwards of 80 to 100 abstract reviewers, and we're always looking for more people. So do get involved. It's a brilliant way of being involved in a meeting. And of course, we can look at peer review publication in any of the journals. And I talked before about meeting participation, but there's more to just being in the audience. Perhaps you're on the podium, perhaps you're chairing, perhaps you've got a poster to present. So all of those things are possible with good collaboration. The highest level of collaboration probably involves proper research, multi-center studies, which we would love to engage with. What that, of course, I mean, I can't tell you exactly what that looked like, but it could be many things. It might just be that between the two associations, we can look at something that is relevant to both in a huge way, look at practice-changing research, and actually when you have the might of two big organizations behind you, that would be world-leading, wouldn't it? It would really be truly impactful. We could look at training opportunities, reciprocal, and we've talked a bit about fellowships already, so I won't talk about that. So different levels of collaboration. I wanted to spend a couple of seconds talking about the Global Training Initiative. This has been spearheaded by Professor Joe Phillip, who is the President-elect of BAUS. He will be taking over from me in June when I become past my sell-by date, and he will be an amazing ambassador for British urology. And this is a new initiative. We are completely, fully funding a 4-week intense training block anywhere in the world that our members wish to go. And this is limited for senior trainees and consultants in the first 10 years. The idea being that they have 4 weeks somewhere else, attend that national conference, and also have a reciprocal arrangement so that people in other countries can come to the UK, greater experience, and also attend our meeting. So we're really very excited about that, and I hope very much that colleagues in this room will be able to participate in that. I wanted to spend a bit of time on our national audit program because I think this is another great area for academic collaboration. We have a host of different audits. Some of these are done and dusted. We've learned from them and we've moved on. Others, such as the penile fracture audit, has been done, but we are still analysing the outcome. And we have the boomerang audit right at the bottom here on the right. That is about recurrent UTIs, and we're just in the process of data collecting. And wouldn't it be great, if these audits that have already been designed, wouldn't it be great for them to be accessed by other colleagues in different countries, such as Egypt? They may not all be relevant, but it might well be that someone looks at that and thinks, you know, we could easily do that here. We could do it as part of our institution, or indeed as a nationwide initiative in the way that BAUS did. And going on from there, why not think of a joint audit that actually the two associations could do together? And again, that would be massively impactful. None of that has been explored before with any of our other relations, and this would really be a first for all of us, I think. How do we facilitate collaboration, academic collaboration? I think we need enthusiasm. It's not going to work if one person stands at a podium and talks and nobody else is engaging. So we need enthusiasm from both sides, representation from both sides. And of course, that mutual understanding that we talked about before, which implies a true, long-lasting friendship. And of course, it takes time. You can't generate good levels of collaboration overnight. It does take time, and I think we're all, as surgeons, I think we're prone to be slightly impatient, and perhaps we just need to be conscious that not everything happens overnight. The key, of course, the bridge between our two associations is the British Egyptian Medical Association of Urologists, BEMA, and we're very excited to be working as a triad of organisations. So in summary, I think any level and all levels of collaboration, academic collaboration, are possible. We've got that global training initiative, which I think will promote things very quickly. Real massive potential with our audit collaboration. And the natural bridge, as I said, is BEMA, of course. I'd like to thank you again very, very much for inviting me. It's an absolute honour to be here, and I look forward to chatting and meeting many of you in the next 3 or 4 days. And I'm just going to leave you with a slight plug for our annual conference next year in London. Again, I'd love to see as many of you there as possible. I can assure you of an equally warm welcome that you've given me. Thank you very much.
I'm pretty sure you're already reaching the maximum, so we'll be in a hurry. Giving you a quick note about the BEMA Urology. So it launched around December 2024. We were about 130 urologists between consultants and middle grades. Most of us are members of different urology societies, mainly the BAUS and EAU, IBIS, which is the International British Urology Society, and ABIS, which is the Arab British Urology Society. The general aims remain the same: establishing a network of professional support for Egyptian urologists working within the UK, improve the ties with other societies, provide support for the urologists in Egypt and abroad, and also to consolidate our movement. So instead of having individuals working with societies, we want it to be unified, labeled as Egyptian activity rather than individualized activity. This is done by two perspectives: supporting and enhancing the standards of Egyptian urologists in the UK, as well as addressing means of helping the medical profession and healthcare system in Egypt. We've had few main basic activities. I'll run it quickly. The main thing is supporting Egyptian doctors going through different exam processes. We've done the ST3 training course, which was an online course helping doctors who are going through the training scheme in the UK. We do regular FRCS Urology Viva course, which is done twice a year. We had, last time we had about 24 candidates, including Egyptians and Arab candidates. The faculty were all mostly Egyptians, and we're hoping to expand our approach to be serving all the candidates for the FRCS. We have the portfolio pathway. As I said, there was about 950 attendants, where for the urology we had about 35 attendees. This is participation in the international conferences that were held in the UK lately. We're not showing these pictures to show that we attend. We're showing them to say that when we are doing it as a unified stand of Egyptians, we are participating and we're winning prizes. I'm showing you these pictures of presentations and chairing of sessions. This obviously Professor Abu Al-Ain, and there's Professor Yasser Farhat attending and representing the Egyptians in the BAUS. Again, this is a few of my colleagues attending. This is Mr. Mo Bilal, Vice President for BAUS as well with us. This is the conference for the International British Urology Society, presenting and winning prizes. SIU, again, participation. We're presenting. We're not presenting ourselves. We're presenting the whole community of Egyptian urologists in the UK. Again, in the EROS for the robotics, in the Arab Association of Urology, presenting and winning the prizes, and as usual, Professor Pierce supporting us and always with us. Now it comes to what we are aiming to do in Egypt. We're trying to build bridges of support and collaboration between the educational systems here in Egypt and in the UK, trying to generate two-way training opportunities. As Professor Pierce has said in his presentation, there is an international training initiative which we are hoping to be able to have something similar between Egypt and the UK. We started by doing the Memorandum of Understanding with Professor Abul Anain during his attendance, and we were privileged to have him among us. We also had Joe Phillip, the President-elect of BAUS, who kindly attended our ceremony celebrating Professor Abul Anain. And then the upcoming projects. So to start with, we're planning to launch the BIMA Egyptian Urology Association Urology online webinar. It will be a 1 hour once monthly. We'll choose one topic for each subspecialty. We'll get experts from the UK and parallel experts from Egypt who will be nominated by the EUA to participate in debatable topics in each subspecialty. We'll get the juniors to present the latest abstracts, and it will be certified. This will be done on a monthly basis. Also, we are hoping to have an annual EUA BIMA session where we will present the best of BAUS to make sure that we have similar discussion to what we have in BAUS. People who have missed attending the BAUS can enjoy and actually get the benefits of the session here in Egypt. We're planning to have an EUA BIMA FRCS Urology crash course. It's still a preliminary idea, but to give you a perspective, it's running a competition about the FRCS. Everybody is invited, and there's a lot of ideas, some of which Professor Murad has proposed. The winners could have an invitation to attend the BAUS conference, fully sponsored by the EUA. There are other projects that are yet to be confirmed. We are looking to have some sort of collaboration in the work on the urological guidelines, Egyptian urological guidelines. We're planning to announce the BIMA Academy, and this is going to offer postgraduate, including master's and MD degrees in the UK. It is going to be online based. A board of professors worldwide are going to be involved. The curriculum will include will be for different specialities, including, of course, the urology. And we're already recognized by 2 universities in the UK. And we're hoping, as Professor Pierce has said, to have in collaborative work with the BAUS. We're yet to have a meeting with Professor Abul Anain and Professor Murad to see the terms and what we can agree on. Hopefully, as we attend here, we're hoping to see as many of the members of the Egyptian Urology Society to attend in BAUS, and I'm hoping Professor Pierce will manage to reduce the membership fees for the international members so that we have actually some sort of collaboration together. And lastly, I'd like to obviously invite you all to attend to the BAUS annual conference next time. It's going to be in London in June 2026. Any questions? I don't think this is a session that I'll be waiting for any questions, but I'd like to thank you very much. This is my contact details if there's any questions. Thank you very much.
Thank you very much, Dr. Hassan. Of course, we are looking forward to have a very strict and more expanded collaboration between Egyptian urology and the British Association of Urology, of course. Yeah, I think I'm thinking now in this moment to have some dual invitation from the Egyptian Association of Urology to the BAUS and vice versa, we can organize a sort of meeting or small conference including both sides, and half of the program will be done by the British urologist and the other half will be done by the program of Europe, that urology beyond Europe. So because we have to cross the borders and we have to fill the bridge, because the two ends should be encouraged to meet in the middle. And we have in Egypt a lot to give to you, and you also vice versa have a lot to give to us. And I think we have to continue collaboration, and the invitation is open. Then we can sit together and make some sort of agreement and finalize the agreement's rules, and it will be benefit for both sides in the future. I remember at one time in Mansoura we have a similar collaboration with Swedish Urology Association, and they regulated a visit regularly every year to come to a couple of days in Mansoura, but it was a very small and very limited. Now I have the same feeling that we can do it on a larger scale and have by invitation from both sides. I think it would be very fruitful, of course. Thank you very much for attending the session, and for you, for our guests, for Ian Pierce and Dr. Hussam. And now at a time of coffee break and then come back. Thank you very much.
Yes. No. No. Yes. No. No. Yes. No. No. Yes. No.
Bismillah ar-Rahman ar-Rahim. It's our pleasure to start our program. I hope that we stick to the time. I have the pleasure to introduce Professor Ahmed Al-Saqqa, Emeritus Professor of Urology and Andrology, Suez Canal University. Dr. Ahmed is one of the pioneers of andrology. He has a lot of publications about this subject. He is a world expert in sexual diseases and andrology. تفضل دكتور أحمد.
Thank you, Mr. Sherman, for the nice introduction. Actually, it's my pleasure to be with you today. Today, I'm going to talk about surgery-free treatment for Peyronie's disease. Is it a reality? First of all, I would like just to remind you with the definition of Peyronie's disease. It's a localized connective tissue disorder that primarily affects the tunica albuginea and the erectile tissue. And also the course of Peyronie's disease is really very variable. In most of the cases are stable, whether it's no change or gradual progression. However, minority of cases may have some resolution, and it's actually very scarce to find a complete resolution. Regarding the medical management of Peyronie's disease, it's actually eluded urologists. Since long time, definitive management has been actually not achieved till the moment. Many historical treatments for Peyronie's disease with varying rates of success were reported. In one of our recent publications, published in Andrology 2021, we have looked at the medical, non-invasive, and the minimally invasive treatment for Peyronie's disease in a systematic review manner. Actually, we categorize all the available treatment, like medical treatment, starting from vitamin A, butaba, colchicine, tamoxifen, acetyl L-carnitine, and others, and minimally invasive treatment like intralesional injection with corticosteroid, orgotin, verapamil, interferon, and more recently collagenase clostridium histolyticum, and non-invasive management like topical management, whether verapamil or also using of iontophoresis, and also extracorporeal shockwave therapy. I'm gonna elaborate more in this methods, and mechanical therapy for Peyronie's disease with vacuum devices and the penile traction therapy. Regarding bentixofilline, which is the non-specific cyclic AMP BDE inhibitor as a therapeutic agent for treatment of Peyronie's disease, it's used actually still very investigational, because it's tried and give a very promising results in the animal model. However, in the human, it's not that good. So it's still investigational. PDE5 inhibitor have long been used for treatment of ED. However, for Peyronie's disease, it's also it's not settled yet. Other agents like coenzyme Q10 and omega-3 fatty acid, they actually randomized clinical trial failed to show such a significant improvement. Looking at this data, actually interesting data, they showed that here, if you look at the recommendation for all of them, for the recommended here, nothing of them actually is recommended as a treatment. However, if you look also at the recommendation against their use, you will find also there is some recommendation against their uses, like here in Butaba, there is a recommendation against, and also tamoxifen. So it's till the moment there is no clear oral treatment for Peyronie's disease. Looking at the data from Egyptian Urological Association, it's actually declared the third edition recently. So also we have our own vision for that. And we said that here, clinician may offer oral non-steroidal anti-inflammatory for pain management, and the clinician should not offer therapy with vitamin E, tamoxifen, procarbazine, omega-3, or others for Peyronie's disease. How about intralesional therapy? It's also, when you look at the available data here for corticosteroids, collagenase, or glutein interferon alpha 2b, and the verapamil, you will find that only verapamil and the interferon and recently Xiaflex or collagenase had been reported for treatment of Peyronie's disease. So if you look at the benefit of the intralesional, it's contrast to oral therapy. It's a direct injection of the substance into the plaque with with a higher concentration of the drug into the local tissue. This is the benefit. However, frequent intralesional injection needs the patient motivation and compliance, and sometimes it's not there. How about Xiaflex? Xiaflex, which is a collagenase Clostridium histolyticum, is the first FDA approved medicine to treat Peyronie's disease, and was first approved for treatment of dubious contracture at 2010. Xiaflex is believed to work for Peyronie's disease by breaking down the build-up of collagen that cause the curative deformity. Looking at the data here also for the recommendation, you will find, yes, there is a recommendation for using interferon alpha 2b, and also for verapamil and the collagenase Clostridium histolyticum. Also regarding the Egyptian guideline, clinician may offer intralesional verapamil for treatment of patient with Peyronie's disease, and patient should be counseled for the side effect for verapamil injection, like pain, bruising, dizziness, nausea, and pain at the site of injection. Clinician may administer intralesional Xiaflex or collagenase in combination with modeling by the clinician or by the patient. Clinician should also counsel the patient for side effect, especially although it's very rare, but also should be counseled with the patient, which is corporal rupture. It could happen in some patients. How about local treatment? Local treatment like iodine, mercury, iodoform, camphor, dimethyl cyphosphide, and the others actually were reported. However, there is no consensus regarding their efficacy. Iontophoresis, which involve application of an external electrical force to induce electromotive penetration of topical medication, was also reported. Looking at the recommendation here, you will find it's nothing, no. So there is no recommendation of any of them to be used. Also here for the Egyptian guideline, clinicians should not offer electromotive therapy for treatment of Peyronie's disease. Other treatment modalities like shockwave therapy, X-ray, ultrasound, and laser. X-ray, ultrasound, and laser, they are not actually recommended as a treatment for Peyronie's disease, but for shockwave therapy, I'm gonna elaborate a little bit about that. Extracorporeal shockwave therapy, it's adopted for treatment of Peyronie's disease over the last decade. Improvement of some symptoms associated with Peyronie's disease was reported. Despite unreported severe side effects, available data did not rationalize using of shockwave therapy as a standard first-line treatment for Peyronie's disease. And shockwave therapy could enhance pain relief. However, using an expensive method such as shockwave to treat naturally resolved symptom is questionable. In one of our recent publication also, we have looked at extracorporeal shockwave therapy in Peyronie's disease in a systematic review and meta-analysis manner. And actually, we looked at, started with 72 studies. Only we end up with, at the end here of this algorithm, we end up with only 3 randomized clinical trial. We analyze all the data of these things. This is actually Chatelli studies and Belmiro and Hitch-Christo. And we actually found also some good results. However, we have not get a solid result. So if you look at the result here for this first plot and bold data about the shockwave therapy in benign deviation, you will see it's actually right in the middle. So there is no efficacy, no much efficacy of shockwave regarding inclination or deviation of the penis. If you look at the one for the Blake size, there is some decrease in Blake size. However, it's not clinically significant improvement. And we conclude in this study, in this meta-analysis and systematic review, the available data regarding the role of shockwave therapy in Peyronie's disease suffer from heterogeneity, and the current data suggests that shockwave therapy fails to improve benign curvature or pain in men with Peyronie's disease. Although shockwave therapy may reduce Blake size, this remains of questionable clinical significance, and further studies are required to confirm finding. Also, Egyptian guideline, clinicians should not use shockwave therapy for the reduction of benign curvature or Blake size. Clinician may offer shockwave to improve benign pain. Clinicians should not use, as I mentioned at the beginning, radiotherapy or laser therapy for Peyronie's disease. Other treatment modality like benign traction, it's interesting that benign traction therapy is a novel modality that require, however, it needs a great deal of patient compliance and determination. This non-invasive modality has generated only preliminary results, and further studies are needed to confirm better the optimal patient population and to demonstrate its efficacy. Is there any new data, any agent in the future to be used for Peyronie's disease? Yes, there is some, like H100, it's topical treatment, which is compound of nicredipine, superoxide dismulate, and there is a potential novel story for this agent. However, it's not yet available. Other agents were used in vitro, and actually like inhibin and ROT inhibitors, their results is encouraging. However, it's still investigational. So they mentioned that they have potential novel efficacy. And finally, also the adipocyte-derived stem cell. Many studies here, if you look here, you can see many studies for using of a stem cell as a treatment of Peyronie's disease. It's actually reduce the expression of collagen 1 and alpha smooth muscle actin, and can be tested in combination therapy for Peyronie's disease. So in conclusion, it is unexpected to assess value for treatment without well-documented randomized placebo-controlled large-scale clinical studies. As scientific breakthroughs in the understanding of the mechanisms of this disease, optimistically in the near future, we may witness evolution in minimally invasive treatment for Peyronie's disease and the emergence of efficacious new agents and the modality of treatment for that devastating condition. Thank you very much. Any question, any comment, I'll be happy to respond.
Thank you, Professor El-Sa'a. And because of this is like a state-of-art lecture, so we will not have questions.
Okay.
So thank you so much, Professor Sa'a. And I'm honored right now to introduce our dear friend, Dr. Daniel Osmanov from Germany. He's a professor of urology and vice chair of the urology department at the University Hospital of Slovic at the campus of Lopec. He's the chair of the educational committee of the European Society of Sexual Medicine, as well as Dr. Daniel Osmanov is a very well-known prosthetic surgeon all over the world. We have the pleasure to have you with us today, Dr. Daniel, and he will give us a lecture titled, What I Wish I Had Known Earlier in My Penile Prosthetic Career. Dr. Daniel, the floor is yours.
Thank you very much. Dear ladies and gentlemen, dear colleagues, I'm very honored to be here in Cairo, in the beautiful city of Cairo, and I had the privilege to spend 2 wonderful days and weekend with my good friend of mine, Professor Ahmed Ragheb. Professor Ahmed Ragheb was one of my first fellows in Kiel. I used to work in Kiel 25 years, and now I moved to Lübeck, which is 100 kilometers, and we are in so-called University Medical Center Schleswig-Holstein. I'm penile prosthetic urologist, but I'm also responsible for robotic surgery. But today we will talk about penile prosthesis, and this is more a clinical-oriented lecture. What I wish I had known earlier in my penile prosthetic career. This is my slide. It's exploring my interests, and I'm a medical advisor for Urological, Coloplast Borges, as well as Boston Scientific. What did I start? How did I start? I started with a perforation of the proximal corpora. So I made, it was 2004, already 600 laparoscopic prostatectomies, and it was easier for me, at least what I was thinking, to implant penile prosthesis. And very first implantation started with the view of asymmetrical Brooks dilators and demonstrating clear proximal perforation. And I asked my chairman, Pete Uniman, what to do. He said, and that was the strategy back to those days, 20 years ago. He told me insert or reinsert the prosthesis using windsock. So I did, and the day after I saw fluid coming out through the drain, and it was probably intestinal fluid. So I perforated rectum, and I called Stephen Wilson, a very known person in this field, my future mentor, and she just said on telephone, Daniel, your problem is QBM. And I asked him, what is the QBM? I couldn't find any evidence in the literature what QBM is. And he said, that's what you have to find out in your life. So, and I started to learn how to make it properly, and the bottom line of this case, from this case, was not to use sharp instruments, especially scissors, by dilating to proximal, and you should dilate, even in virgin cases, gentle without violence. And I started to learn anatomy in the Institute of Anatomy. We have a wonderful laboratory with great specimens demonstrating all anatomical peculiarities of the pelvis, of the penis. At that time point, I couldn't find information about QBM. But I started to implant more, and I should have known that there is another way of fixation of the proximal part of the prosthesis opposed to using windsock, and this is the rear tip extender sling maneuver. So you can just attach the perforated side or affected side of the proximal corpora to the prosthesis or to the rear tip extender using a simple sling maneuver. That could make a difference in my case. And this is the case of another perforation on the left side, and I managed this with rear tip extender sling, and then that was easy to perform and could avoid a lot of problems, in particular perforation of the rectum. There are a lot of safety checks you have to think about. They are very easy and to perform, and actually logical to explain. So the first is the goalpost test or goalpost maneuver. You have to insert your dilator. I use Brooks dilator, and then you can see the difference of the position of these dilators. If they are one of the dilators too high, you have probably perforated to proximal, and if they have a different angle, you have probably crossover. Another safety check is the proof of the integrity of the urethra, and that can be easily done if you irrigate urethra, or actually you irrigate the proximal part of the corpora with saline, and if you see the fluid coming out around the catheter, you have probably perforated distal urethra. In this case, we recommend to stop implantation and then to come another day, because if you have perforation in the urethra, you have probably infected area in this part of the penis. And the third one is the distal goalpost maneuver. You can do it as well. And with this maneuver, you can exclude two conditions. You can exclude the impending erosion of the distal part of the corpora and finally urethral perforation. So we all know this situation, and some patients have impending erosion, or some parts of the prosthesis could be visible. In this part it is visible, but it is not broke through, it is impending erosion. And this patient came back to me with this condition. What would you do in this situation? Well, this can happen because some of the devices have longer tubing, and in combination with the smaller scrotum, you have permanent pressure to the skin, and your pump is always under pressure attached to the skin, and that can cause perforation through the skin, and that's the reason why you have to customize your tubing. And if a case of longer tubings, you have to use less rear tip extenders, then you would have less tension to the skin. In some of the brands, prostheses, you have to use rear tip extenders because the length of the tubing is standard despite of the length of the cylinders. But the modern prostheses in all brands, they customize the length of the tubings to the length of the cylinder. I changed my strategy in order to avoid it, and I had a couple of those impending erosions and also true erosions of the pump, and I'm placing the pump posteriorly in the scrotum instead of making a subdarterous pouch anterior part of the scrotum, and I close in several layers and spent a lot of time, maybe 20% of the whole surgical time, in order to place the pump, because it's very important. On the one hand, it shouldn't protrude. On the other hand, the patient must have a very nice tactile filling after placing a pump. Many high-volume implanters use a drain, and I do recommend it because using a drain, you can reduce the risk of hematoma. And I believe that if you have an infection or IPP-associated infections, that is because of the hematoma formation. And we can, according to EBM, see the hematoma incidence is around 10%. So by putting a drain, you will reduce this risk. I also recommend to wrap the scrotum, and we are in the land of Pharaoh, and I use the mummy wrap, it's just described by Henry, in order to apply additional tension to the scrotum and reduce the hematoma in combination with the drain. It is good to know that in some of the cases you may have prosthesis coming out through the skin, especially if you have artificial urinary sphincter. And we know that all components, artificial materials in the body, which is all prosthetics and also dentin plug, they have a biofilm, just like a clogging of oil pipelines. And they have also a capsule around the prosthesis. And curiously, some patients do well with protruded materials because in this case they have probably non-aggressive bacteria in the area. And it is, as I already mentioned, you can see it in AUS patient, artificial urinary sphincter, and even in this patient you see that has no pain, no signs of infection in the blood, and the initial strategy was if you see the material, you have to take it out, you have to take everything out. But in such cases, we have a shift of paradigm. If the patient has no infection or no visible sign of infection, and in the blood no sites of infection, you can stitch it up, you can cover it, put him under long-term antibiotics like gentamicin, vancomycin, and wait. And the worst thing can happen that he will probably have, or maybe not, infection, and if so, you can remove it afterwards. But in this case, you have a chance to keep prosthesis on place. There is some new studies, and actually this is one of the main study of the last decade, published in Journal Sexual Medicine by Martin Gross, and he examined the cases of explanted devices, and all these explanted devices had a microbiological specimen, so they took a swabs after taking a prosthesis out in 25 American centers. And he found out all these bacteria, well, which is a little bit boring, but if you focus on a couple of them, you can find that 11%, more than 11% of these agents, fungal infection, candida infection, and anaerobic bacteria, as well as multi-resistant bacteria. And if you look to the current EAU and SMSNA recommendations, and European and American recommendations, we can see that at least 14 to 40% of cases, if you have the patients with the fungal infection and anaerobic bacteria, they are not covered by the current prophylaxis. So we have to change our strategies of prophylaxis towards finding another solutions in prevention of infections, of potential infections with candida and multi-resistant bacteria. It is interesting, and there is an evidence that the bugs have changes because of infections retarded coatings of the prosthesis. And all these ideas of no touch, of changing gloves, or cover the field with some plastic materials in order to reduce the contact with the skin, not necessary. There is no evidence that that may help. The only evidence which is really evident that you have to reduce or keep on time and you finish your surgery, a surgery should be done in less than 60 minutes. We know that the device infection reduced from 4% in non-coated area to less than 1% of the coated area. However, we believe that these coated materials, the coated feature of the prosthesis, such as inhibit zone and hydrophilic coating, probably work only against wimpy skin organism, and probably not protected against the multi-resistant bacteria. Another interesting idea actually came up from Astoni and Paolo Egidio to make the penis longer by the so-called sliding technique. We stopped doing that. We started in the beginning because we have a number of complications, and we know that the length or lengthening of the penis by this method can be done only plus 3 centimeters. So you can only make the penis longer up to 3 centimeters. And of course, if you take into account the infections, such IPP-associated infections and glands necrosis, which can be seen in over 20% of the cases. So think about your patients, whether you want to risk your patient in order to make his penis 3 centimeters longer, and taking into account all these complications. IPP, so inflatable penile prosthesis associated with Peyronie's disease, we all use them, and there are a lot of strategies how to use operation, so IPP placement, to treat the Peyronie's disease and severe curvature. As you know, Stephen Wilson published so-called modeling technique, so he straightened the penis using inflated device. There are another alternatives, and important is to notice that it is not possible to straighten the penis immediately, and you would have still curvature or still deformation of the penis after modeling procedure, because the prosthesis cannot improve or straighten your penis immediately, and it works as a tissue expander, and it needs time. to make your penis straight. And effectiveness has been described with 83 to nearly 89% in patients with Peyronie's disease. The history is very